Good morning. We'll try to get things started and keep this on time for you guys. We really appreciate you taking time out of your Sunday. And it's also great to see everybody in person. It's been two and a half years since we've seen people in person, and we really appreciate you guys coming out and joining us. We do have a couple people virtually as well, but it's great to get back seeing people in person and a little more normalcy. So we really appreciate it. So obviously this is our continuing education event. We're from the Eye Care Center of Northern Colorado. We have our practice and our surgery center form our group. We have a number of different providers, as many of you guys know. We have retina team made up of Dr. Tilton, myself, Justin Canoff, Matt Manry, and then Carl Noble, who will be presenting first. We have our glaucoma and cataract team with Micah Rothstein, Anjali Sheth, who will be presenting later, and then also Mansi Parikh. We have our oculoplastics and cataract team with Dr. Myers, who has joined us even though he's not speaking. Maybe we'll get him to say a word or two. And then Dr. Werner, who's going to be joining us virtually and giving her presentation. And then the newest member of our team is Diane Siegel. She did her residency at the University of Colorado and joined us about 3 weeks ago. And she's doing great, and we're excited to have her. She's doing general ophthalmology and cataract surgery. And then we also have the 4 members of our primary and comprehensive eye care team, Dr. Crone, Dr. Wolford, Dr. Burton, and then Dr. Bartlett, who joined us about a year ago. And then this meeting is provided with some grant support by Glaukos. And they do corneal cross-linking, and they also do a MIGS procedure, the eye stent inject for glaucoma surgery. And it says the Glaukos exhibit is here, but that doesn't seem, hey Priscilla, is that really the Glaukos exhibit? It's behind the corner. I guess they got banished. They're not allowed to be in the same room, so they're sort of sitting back there. So at some point, maybe try to say hi so they're not so depressed back there. FYI, the clicker does not work well. Okay. And then we also have the Advanced Vision Surgery Center, which is our surgery center in Longmont where we do all of our surgeries. And really, I'm not sure if any of you guys are familiar with it, but it really allows us to take great care of patients. It's only for eye surgery. A lot of surgery centers, they do a whole combination of stuff. The nurses might take care of orthopedics or other cases, but our nurses and our staff, all they do is eye surgery, so we get great outcomes there. The other opportunity, if any of you guys are interested, you guys are more than welcome to come and visit us and watch surgery. If you just sort of give Priscilla an email, we can arrange that for anybody who's interested to see cataract surgery, retina surgery, glaucoma. Just let us know what you're interested in, and we can sort of hook you up with the right day to sort of visit. Okay, I think the clicker is not going to be the way to go. There we go. Okay, and we have a number of different locations for us to be able to see your patients in Longmont, Boulder, Lafayette, and Greeley. And then the newest place we're going to be seeing retina patients starting in November is Dr. Noble is going to be going to see patients in Golden. And so that's another opportunity if that's a better location for retina patients. Okay, great. Okay, so it's another thing I just want to sort of highlight. I think there's, obviously we know there's a lot of different groups out there, and I think one of the big advantages we really have is the breadth of our ophthalmology specialties. That really, if a patient comes to see us for a retina consult or a glaucoma consult or a cataract consult, if there's any questions, there's a retina physician down the hall, or a glaucoma physician down the hall, and I think it's really this team approach of how we're able to take care of patients with all of the different specialties under one roof that really allows us to get great outcomes. We've seen we've seen a number of sort of situations where patients have gotten into trouble where they didn't really have, access to glaucoma or access to retina because, the group didn't have that coverage. And I think it's really a benefit we have for patients that we can really take care of all their issues sort of under one roof. So without further ado, Dr. Noble is going to talk about OCTs and make us all experts in the reading of OCTs.
Looks like that works. This is on. Okay, cool. Well, I'm Carl Noble. I'm one of the retina folk. What's up? Right up on it. Is that better? I'll just stand like this the whole time. It'll work out really well. I'll just grab it. Can I hold it? Just walk around with it. Awesome. Okay, so can you guys hear me? Awesome. So I'm going to talk about OCT. We've gotten a lot of feedback from different presentations that OCT is something people want more of. And so we'll kind of talk about things. I don't think we'll make experts out of everybody. OCT is a constantly, evolving technology and something that I sometimes still am having to look up a lot of things on OCT. This is just amazing technology. It continues to get better, and I think most of us are using it on a pretty regular basis. How many people have OCT in their office and are using it relatively frequently? Anybody have formal training with OCT, like in their training process? Or is it something everyone just kind of learned on the fly? Usually most people are like, I just learned it on the fly. So that's how most of us learned OCT. And I think that's why it can be difficult to understand what we're looking at and then also correlate what we're seeing. Is it clinically significant and does it require intervention, or is it just kind of an interesting finding? I think that is sometimes what's tough about OCT. So we're going to be looking at OCT imaging, kind of doing some historical perspective, talking about anatomical correlations, understanding the outer retina. I think from a surgical perspective, that's what I care a lot about, is looking at that outer retina. And then go through some pathological correlates, and then have some videos and some stuff, and you guys can ask questions at any point. Just yell maybe really loudly, and then I'll stop, or we can do it at the end. But I respond well to yelling. So OCT, this is just a cross-sectional analysis that we're looking at really any tissue. You could get an OCT through your arm if you wanted to, but usually we focus with ophthalmology on the back of the eye, looking at either the optic nerve or the macula. I'm very biased. I think just the retina matters. I'm not sure what the nerve does, but we usually are looking at the fovea. And so some of the advantages with OCT, this is really amazing that we can get histologic detailed imaging on patients with a non-invasive intervention or non-invasive imaging modality. There's no radiation, there's no contact for the patient, and it's pretty quick as well. And so this is pretty phenomenal technology that we can get these images. Anyone used OCT in the 90s? It was really bad. And before that, it was kind of just like a research thing. But as we've gotten better and better A-scan per second, and that's really increased 100-fold, and now we're getting these really high quality from the time domain to the spectral domain. Went from 100 A-scans per second to 27,000 A-scans in 2006, and now we're about 40,000 A-scans per second. So that's why the technology just keeps getting better, and the scans have just such high quality now. Swept source, has anyone used a swept source before? I would guess not. It's not very common in people's practice. It's mostly used for research, and I just wanted to highlight this is the difference between the Fourier domain and time domain. So let me know if anybody wants to work out these math equations. I'm happy to email them to you, but kind of above my calculus 2 from undergrad, but there's math involved. I just wanted to highlight that. So swept source, spectral domain. Swept source, again, is more of a research thing. It's really expensive. The machines are very expensive. And so I think why most people haven't purchased those or incorporated them into their practice. Swept source gives really good image quality. I think this is the laser. Oh, look at that. It works. So you can see here the choriocapillaris in the vitreous is super well highlighted in the swept source image. It's still there, I mean, on the spectral domain, but just really good image and light penetrance for showing kind of that choriocapillaris. Otherwise, I think the actual retinal imaging is about the same as far as what you're looking at, but the swept source just gives really good detail of the vitreous and the choriocapillaris, but most people aren't using it because of the price is the biggest factor, and I think all of us are kind of slow to change what we have in our clinics, and switching from one machine type to another, if there's a price factor involved, we're probably not going to do that. So I think that's the biggest factor. So OCTA, does anyone have OCTA in their office? I assume not. I assume not. Yeah, most people aren't using this in general practice. Some people will buy a machine and they have it on their, the software's already on their OCT. That's why I ask. It's pretty cool technology, and we're using B scans at a really high frequency and then looking at the difference in movement in the back of the eye. The only thing that should be moving is blood, and so that's really what it's measuring is flow. And this technology is really taken off. It's not really that new anymore, and kind of went from the lab now to being involved in a lot of people's practices. And I think you get different opinions on how helpful or not helpful OCTA is. I personally really like it. Some people find it not that helpful for making clinical decisions, but it does get really cool pictures if that's nothing else. So this is a patient who has new vision loss. I saw it at the Veterans Hospital when I was a fellow. You can see subretinal fluid there and subretinal hemorrhage. He's got a fibrovascular pigment epithelial attachment with subretinal fluid, and then this really beautiful vascular net in a classic or type 2 choroidal neovascular membrane that you can see there. It's really nice. So I think the cons of OCTA are what most people focus on. I think artifacts, the biggest issue is that if patients are moving or if they have really bad dry eyes, it can be hard to acquire a good image. And artifacts can make things look pathologic when they're not. You can get these kind of artifact changes that look like maybe that's a net, maybe it's not. But I think all those things can be worked around. I'm a pretty big fan of OCTA, so obviously I'm doing this presentation, so I can be as biased as I want. But it's, again, a non-invasive thing. So we can use, instead of fluorescein angiography, we can get OCTA, and for a lot of posterior polar pathology, it's super helpful. Fluorescein's invasive, and patients can have bad reactions to fluorescein, so I really like it. I find it really helpful for those type 1 choroidal neovascular membranes that are underneath the RPE when you're trying to decide should we treat or not treat. And I typically don't get fluoresceins for like wet AMD or choroidal neovascular membranes. I usually get OCTA or just an OCT. So we're going to talk about the anatomy of the OCT. I think the biggest thing to take away from this is that there's the inner retina portion. It goes from about here up, and then you have the outer retina here. And this is where your rods and your cones lie. So stuff that happens here, you can probably get away with a little bit of time and may or may not need to intervene. I'm being super general here. Down here, if these cells get damaged, you're probably not going to get that tissue back. So here's bad, really bad. Here's can be very bad, but less bad than down here. I think that's the biggest thing to take away. So when we look at the different, we'll kind of run through this, but you have your hyaloid here, posterior cortical hyaloid. You have your internal limiting membrane, which is connected to your external limiting membrane by the foot plates of Mueller here. They kind of have communication. You have your nerve fiber layer, your ganglion cell layer, your inner plexiform, inner nuclear, outer plexiform, outer nuclear, and there's that ELM. And sometimes this line, I think people get confused by what is that line, and it's not a cellular or visually significant line. I mean, you don't want to get rid of it. It'd be pretty hard to remove it, but I think people get confused with this as being retina. And then we go out to the actual outer retina here, where you have your easy zone or ellipsoid zone, and then you have your outer segment zone here, interdigitation zone, and then your RPE. I think it's a good reference point is just find your RPE. So if you're looking at OCT and you're like, what layer am I looking at? Go all the way down. The whitest portion or the brightest line at the bottom is going to be your RPE. You know, OCT works by measuring reflectance. So the more dense tissue is going to have more reflectance and look more white. So liquid or vitreous is going to look dark. RPE, the most dense layer of the retina here, is going to look the whitest. So try to find that layer, and that'll really help you understand where you are. And again, this is just kind of highlighting a more of a magnified zone here. You have your ellipsoid zone, your cost or interdigitation zone, and this is rods and cones. This is kind of where they originate, and then your RPE here. So again, these layers here are your actual, when we say like if there's subretinal fluid, it's underneath these layers. If you're having a full thickness macular hole, it's damaging these layers. There's no longer tissue connected there. So this is really the most visually significant aspect of the OCT and what patients are actually experiencing when it comes to visual acuity. So there's different ways to get an OCT. You can get a grid, which is kind of a pattern here. And I'm not a huge fan of the grid. It's good for kind of screening, but you have kind of large holes here and you can miss things. But it's a fine OCT to get, and you kind of get a scatter pattern here. You can do it as this horizontal rasters. You can get vertical rasters. And this kind of gives you as many scans as you would like. And you can do a cube even, so it's a continuous scan. You can get a radial scan. I think this is most helpful for foveal pathology, so things like vitreomacular traction and trying to see 360 degrees around that fovea. Now, this is, I think, one of the most important takeaways of this presentation is the posterior cortical hyaloid. So when I look at an OCT, it's one of the first things I look at. Is the gel attached or is it not attached? This person's gel is attached. And so whatever you're seeing, if you're worried about peripheral pathology, is probably not that acute. Probably not. When the gel separates is when most of your peripheral high-risk pathology occurs. PVDs lead to horseshoe tears, which leads to retinal detachments. So if you're seeing a patient and their hyaloid is attached, and you're worried about a peripheral pigmentary change, unsure if this is something significant or not, just if you get an OCT, this will be super helpful for you to know, is this urgent, emergent, or not urgent at all, and something just routine. So really focusing on that hyaloid, I think that's super helpful for patients who are having floaters to know if these are just chronic vitreous degeneration or if this is actually acute PVD. Sometimes you can't see the hyaloid. Usually if you look and it's there, you can find it, but sometimes it's hard to tell. And this is really good for you to be able to confirm that it's attached. It's not always good to confirm that it's detached. But if you see it, you know that they do not have a PVD, if that's helpful. So let's go through some pathological correlates here. So we're going to talk about the way the vitreous interfaces with the fovea or the macula. There's a whole range and a bunch of different classification schema you can use for classifying macular holes. I typically, some of these things are helpful. I think some of them are not. But when you look at this, this is a progression of how much traction there is on the fovea. People who get macular holes have weird vitreous. I know that's not a medical term, but it's very sticky. And so when we're doing surgery and doing a macular hole repair, they usually do not have a posterior vitreous attachment. We're using our vitreous cutter, and we're having to physically aspirate the gel off the optic nerve. And anyone who's done these surgeries can tell you that the gel is really hard to get off the optic nerve, which makes sense because when it was trying to separate off the fovea, it got stuck, caused traction, and that's what led to the hole. So it makes sense, but whenever you try to remove these people's hyaloid surgically, it can be the most challenging portion of the case, just getting the PVD induced. So here we have a grade 1 macular hole. You can see that there's no outer retinal changes, but there's starting to be some intraretinal spaces here. This can progress to a lamellar hole where there's no outer retinal loss, but you have this kind of excavation of tissue changes and kind of this sometimes even schisis or spaces that are created inside of the retina. Here we have an early small macular hole with the vitreous gel still attached. There's kind of this roof, if you will. And then those can spontaneously close on their own if the vitreomacular traction releases, and this can actually spontaneously close. And sometimes you'll see this. You'll see a patient who's just kind of a weird-looking fovea, and the gel is still attached to the optic nerve, and you can often pick these up if you look at the fovea. It just looks a little bit atypical. Here we have a larger macular hole. This has progressed now to a stage 3 macular hole where the gel is still attached to the optic nerve. There's a little operculum here where that tissue popped off. And stage 4 is usually pretty chronic. Like I said, these people's vitreous gel is pretty sticky. And so for them to have a PVD, which is a stage 4 hole, the gel is now separated, it's floating in free space. It usually notes chronicity if that's the case. So here's some examples, some more examples here. This is just an asymptomatic patient who has vitreophobia adhesion. You can see these kind of dove wings here, that's the gel. The fovea doesn't really have that smooth contour here. To me, when you have a normal contour, it kind of looks like a mini ramp. But for those who don't skateboard, you can kind of use whatever example you'd like. But that's what I tell patients. Sometimes they like that, sometimes they don't. But it looks like a mini ramp. And here, this patient's completely asymptomatic, and mostly because this outer retina is intact and not causing issues. Here, we're starting to see that the foveal contour is pretty severely distorted, having some tenting here. And this patient probably has some early symptoms. And here, now you can start to see that that's elevated. So here's your outer retina, and then it pops up right there. It's also kind of schmutzed, just a little bit less clear. You don't see clear line going all the way across. And that word is, again, not medical, but I think it's super helpful. Whenever you see just a blurring of the outer retina, you know it's starting to be irritated. And this patient was symptomatic. Here's another case where you have traction, you have a lamellar hole, where you can see it's kind of popped off there. And they could have had a macular hole that either closed on its own or there was enough traction. You can see those two kind of outer retinal focal defects. And so that's super important for the patient, because if you give them an AMSR grid, they're probably going to notice those. This is a patient who has high myopia, staphylomatous, developed a macular hole, had a really nice anatomical result after surgery. But in this situation, there's almost not enough tissue to kind of cover that bowled out staphylomatous eye. And so these patients can develop macular holes as well. Very difficult to treat surgically. So this is an example of a macular hole repair, kind of a unique one. I thought I'd throw you a curveball. This is a case where a patient, let me see if this will just, there we go. A patient who had 3 separate macular repairs, all of them failed, and had a large chronic macular hole. He's pseudophakic, we did 25 gauge. Let me see if this is, can you guys see that all right? It's coming up a little bit dark on your guys' projection there, but he'd already had an ILM peel, so I'm trying to see if there's any ILM that we can kind of harvest and maybe do a flap, but really wasn't much ILM left. The previous surgeon had done a really nice job with a good membrane peel, almost all the way out to the arcade, so it wasn't really a lot of peeling left. So I tried to do a flap there, but I was like, well, this is a pretty darn large hole you can see there. I think we're going to have to do something else. So we used viscoelastic and kind of put that over the hole just to help with adhesion. We used an amniotic membrane graft, and you'll see that we kind of put it through the trocar there. And then I think the hardest part of these grafts is knowing which side's up and which side's down. It's kind of hard once you're in the eye. So you'll see that we kind of put it in there a couple times and it doesn't stick, and then it ends up flipping around and kind of nicely sealing the hole. Dr. Wolford, you'll appreciate this. It kind of looks like the state of Ohio. If you look closely, once it's all ironed out there, see it? It kind of looks like the state of Ohio. I think so. I think that's why it was so successful. But you'll see here we kind of futz around with it for a little bit, and then we flip it over, and then voila, goes in there really nicely. And this is acting like a scaffolding. There's a couple different ways to repair kind of these complex macular holes. I really enjoy doing those. And so we did a fluid air exchange as well, and then gas, and the patient was face down, kind of like a standard mac hole. But this is something you guys may have not seen before and not super common. There's some decent case series that people have done on these, but I mean, most people have done none or a few of these, and they're kind of a unique way to repair mac holes, but they work really well. And it's really just acting as scaffolding so that the hole can close. This patient did really well. This was their pre-op OCT and then kind of their post-op, and you can see that amniotic membrane is still there and kind of act as scaffolding to close that macular hole. And 2080 doesn't sound like a lot, but this patient had been count fingers for a very long time after 3 surgeries, so 2080 is a pretty darn good result. And maybe if you like pinholes, we can get him to driving during the daytime. So this is another case. I wanted to show you this because I think it really highlights epiretinal proliferation, which is different than epiretinal membranes. So there's different types of lamellar holes. And let me go back. That was pretty darn quick here. So here you'll see that this is called a lamellar hole with epiretinal proliferation. So right there, there's kind of an ERM you'll see is kind of like a white line on top of the retina. This is more a moderate reflective changes on top of the retina, and you'll see this kind of excavation on the sides. And they think this is actually the tissue migrating over the top of the retina and causing this changes on the surface. And you can see pretty significant amount of exudation, this kind of dome-shaped or pillar-shaped area of preserved retinal tissue. This patient had outer retinal changes as well and was very symptomatic, so a decision was made to go to surgery. And I want to do this case just to highlight just kind of how interesting some of these membrane peels can be. This patient, we did a vitrectomy. That's part of the initial portion of any surgery we do with retina usually. And we started by trying to get purchase on this membrane. It was really difficult to get purchase. We just really couldn't grab it with the forceps. So we used a flex loop here. And this is kind of has tines on it. It's just a metallic little loop that can kind of tease up portions of the internal limiting membrane or sometimes the epiretinal membrane. And this case I think is kind of cool just because it really shows you what these membranes can look like. And this one has this kind of gummy, sticky texture to it. And it looks atypical for an epiretinal membrane. And so what we did was we kind of worked our way all the way around this macular hole or lamellar hole and created something called a cabbage leaf flap, where it kind of all goes into what looks like a cabbage leaf. And you kind of tuck that into the macular hole. And so initially we get the membrane up, we restain, and now you can see the green, that's your internal limiting membrane. That's what the ICG green dye highlights. And we kind of work that again around similar to the epiretinal membrane. And that's where that internal limiting membrane is there. And that's that superficial layer of the macula or the retina. And so kind of work that around. And then we'll trim back that flap and then do a fluid air exchange. So this is kind of, a macular hole plus type surgery where we're doing something besides just peeling the internal membrane. So kind of a unique case that highlights really just how interesting those membranes can look. And this was a very atypical membrane that had a very kind of sticky texture to it, which is pretty classic for those lamellar holes with that epiretinal proliferation. And this is just a fluid air exchange, and the patient again went face down. We'll talk about some cystic changes, and I'll keep talking, so let me know if I go over, just kind of someone tell me to shut up. So again, ask questions if you need to. So DME, this is something a lot of us are seeing in our clinics, pretty common for have uncontrolled diabetics. I'm not used to seeing so many well-controlled diabetics. I feel like Boulder County is like the healthiest people on earth. So, but some of them do have DME. And I think the biggest thing when you're trying to decide is this DME or CME, it's sometimes difficult to tell. And there's been some good studies that have looked at this, and the biggest thing to highlight is the hard exudates. And that's kind of these white or reflective areas. And that can be really indicative and really helpful for you to determine is this CME or DME. I always like to, and feel free to steal this, but I like to give the analogy for patients that their vessels are damaged from high blood sugar. The inside lining or the lumen of those vessels has been damaged by the high blood sugar and causes them to leak. Think of an old hose that's been sitting out for decades, and then you turn it on, you get those jets of fluid off the side, and that's what's happening to their vessels. Fluid's leaking out through those capillaries, the pericytes have been damaged by the high blood sugar, and it's leaking out products of blood. And so I think that analogy helps patients understand, or maybe they just nod and say it does, but they humor me. But this is what's happening, that fluid's leaking out. The exudates are actually the lipid component. I don't know if you've ever seen spun down blood, but it separates into like a kind of a yellowy and then a red. So the red is your red blood cells, and the rest is all these other products of blood. And that hard exudates is lipids that's been kind of left behind. This is just more severe diabetic macular edema, more exudates, and these are really toxic to the outer retina and typically cause vision loss if left. This is another more advanced where you can get areas of subretinal fluid. And then this is kind of a oxymoronic statement, but a large microaneurysm, and that's this kind of moderate reflective area here. And with DME, I'm not sure if it's confusing sometimes when you send a patient for a DME evaluation and we treat, and sometimes we don't, and you're like, what the heck's going on? Why are they not treating this person and treating that person? I think visual acuity for most of us is the biggest guide for if we do or do not treat. And there's really good studies with the DRCR is like a big research group that looks at diabetic
retinopathy and how we can best treat it, and try to take clinical, real-world examples of how we can best analyze these patients and to help us with practice. And patients who have preserved vision actually do very well with diabetes. And so 20/25 or better, which was one of the protocols they did, was looked at watching patients with 20/25 or better visual acuity, and they did really well long term. And so patients who have preserved vision, and I have one guy who looks like this, but he's got 20/25 vision. I don't know how the hell he does, but he does. And so we're watching it and not treating. And there's really good data to support that. And then you have some patients who have this and they have 2100 vision. So visual acuity is really a good guide of when and when not to treat. And I think the biggest issue with these patients is long-term is ischemia. And you can see here, outer retina, no outer retina, outer retina, no outer retina, outer retina. And that's all from ischemia. And so this patient probably has poor vision and a big scotoma in the center part of his vision because of his macular ischemia. This is another great example of when OCTA is helpful, because you can show patients the blood flow loss on OCTA, which I think is really nice for them to see and kind of buy into why they're having issues and understand how much it's affecting them. Fluorescein angiography can also be good for that, but the fovea has a foveal avascular zone, and when it's enlarged or we have loss of retinal capillaries, I think OCTA can really help highlight that. Now, this is something that if you see a post-op patient, post-cataract surgery, this is a very classic cystoid macular edema case, and you can see how much different it looks than diabetic macular edema, where you have these large cystoid spaces, so a little bit of subretinal fluid, has kind of this confluent dome-shaped pattern to it, and this is more in the outer plexiform layer, and again, no hard exudates. Again, it's sometimes hard to tell. And if a patient has diabetes and they're a post-op and they have worse swelling, they can have worse swelling from their diabetes, or they can have worse swelling from inflammation. Fluorescein angiography is super helpful for this. If the fluorescein shows leakage from the optic nerve, that's really indicative of an inflammatory cystoid macular edema. If there's no leakage and you see more diabetic changes, that's probably an anti-VEGF deficiency, where this would be a steroid deficiency. So you got to all break it down to how you treat it, but do you need steroids or do you need Avastin or anti-VEGF? And that's sometimes a difficult thing to decide. So pre-retinal membranes, this is kind of what we're used to seeing as kind of a classic idiopathic epiretinal membrane. Some good classification schemas on kind of understanding, what mild and what severe means. But when it comes down to it, it's, again, the outer retina. Is the outer retina involved? And that usually denotes symptoms. So what I tell patients, and one of the first things I ask them is, are you having symptoms? Are you having distortions? Do things look weird when you're reading? Do letters kind of drop off, or do they look broken? Do things look warped? If someone's not having symptoms and their vision's good, they don't need surgery. And so that's a really good thing to kind of tease out from the patient. And sometimes an Amsler grid is really helpful. Most of us don't walk around like this when we're doing things. And so if they have an epiretinal membrane on one side, an Amsler grid kind of forces them to check for distortions. I think that's really helpful. But not all patients with epiretinal membranes, regardless of what they look like, need surgery. And sometimes when they look mild, if it's involving the outer retina, they need surgery. But at the end of the day, it's kind of teasing out the patient's symptoms, how much it's impacting them, and kind of monitoring to see if that surgery would be a benefit for them. This is another example of a type of epiretinal membrane that you'll see with diabetics. This is actually the cortical hyaloid that's been thickened and enveloped with vessels. So proliferative disease is vessels from the retina growing up through the scaffolding in the vitreous. If someone didn't have vitreous, they really couldn't develop a tractional retinal detachment. So that's where the traction comes from. It's the retinal vessels growing up, enveloping into the vitreous. It thickens the vitreous, becomes more of like a membrane, and then causes all sorts of terrible problems. And so this is a thickened posterior cortical hyaloid, which is now causing traction. This is a myopic patient who has an epiretinal membrane here and causing significant amount of traction. I also like to think it's just not enough real estate, not enough retina to kind of cover this big staphylomatous surface. This is another patient who has vitreomacular traction. You can see, again, outer retina is involved. They're symptomatic, having issues, but you can see defect there, and then kind of some traction there. So that's really what to hone in on. And then to have some intraretinal spaces in from that traction. And this is the same eye post-op and really nice anatomical result. And this patient looks pretty lucky. You can see how much better that lamination is there with that outer retinal line. So macular degeneration, I think it's, I get a lot of variance on patients when it comes to what they're taking, how much information they know about their macular degeneration. And I think a lot of these classification schemas that they developed when they did the age-related eye disease study were done without OCT. They were done with fundus photography and fundoscopy. And so a lot of these classification schema, whether it's a small drusen, medium-sized drusen, or a large drusen, is kind of it's still very useful and super helpful, but those classifications were mostly done with exam and fundus photos. So one helpful thing to know if it's large or small, you can use the retinal veins as a guide, and it's about this size, so that's a helpful thing to kind of use if you're deciding whether it's large or small. But if they have kind of rare, small drusen, it's probably early, and there's really no good clinical data that AREDS vitamins are helpful. And so the age-related eye disease study was looking at what's going to help prevent these people from going to advanced macular degeneration, and it really focused on, and what they showed was that the intermediate stage had a 25% risk reduction for developing advanced macular degeneration. So there's no clinical data to support using the AREDS 2 vitamins in early and advanced. It's really for intermediate. And so I just like to let patients know that it's optional. It's not going to hurt you, right? Those vitamins are all helpful vitamins to take. So it's not going to hurt you, but it may or may not help you either. And so it's just nice to have that discussion with the patients and kind of let them make the decision. But at the end of the day, the AREDS vitamins are probably not going to kill anybody, probably not going to have an adverse event with the AREDS vitamins, but it may or may not be helping them. It's exciting with dry macular degeneration, and it's weird saying that. As a retina surgeon, I hate seeing geographic atrophy because we just don't have a lot of good ways to treat it. And so it's really exciting that there are new treatment modalities coming out. I think hopefully in my generation of retina surgeons, we're going to have some better options for patients, and I'll be more excited talking about it to people as opposed to just kind of a depressing topic. Well, seeing those patients can be very depressing and very hard for the patient because they can lose a lot of vision. So this is a patient who has macular degeneration. You can see these RPE elevations, these kind of focal small drusen, more of a confluent drusen there. This is, again, more slides of drusen here. This is probably either earlier or intermediate, depending on what the exam shows. This is a larger drusenoid PED with several other medium and medium or small drusen there. But this would definitely be a large drusen, so a connotate intermediate. This is a serous pigment epithelial detachment, which you can get with macular degeneration. This is something called a retinal pigment epithelial rip, where those PEDs or pigment epithelial detachments can contract, and then they can actually rip. And if it also damages the outer retina, and so patients often have vision loss in that sector. So it's pretty visually significant when that occurs. This is basal laminar drusen. You can see this thickened RPE with this kind of sawtooth pattern. And this is something called SHRM. This is actually AMD, but it's subretinal hyperreflective material. These can be type 1 choroidal neovascular membranes. This is where OCTA can be super helpful to determine if that, I don't know why I was just wandering off there, but super helpful for determining if that's a leaky vessel and if it needs to be treated. And this is, I think what trips most people up is an AVL or adult vitelliform lesion. These on exam look creamy yellow, like Best disease, if you remember those photos. It looks creamy yellow. They're usually asymptomatic, and it's often asymmetric bilateral, so they usually have similar changes in the other eye. These can collapse, though, and so one eye can have no changes, and the other eye may still have these lesions. But over time, these can collapse, and you can also develop secondary choroidal neovascular membranes, less common than in macular degeneration. But these rarely need to be treated. This is geographic atrophy, and on the OCT, you can actually see there's no outer retina there. And the reason it's white down here is because there's no signal blockage. So usually there's RPE, outer retina, that's blocking the signal to a certain degree. That's the reflectance aspect. And so there's nothing blocking it, so you see this signal artifact here. And this is not the same eye, but this is just a really good example of autofluorescence. So on your Optos, you have autofluorescence, and it's really helpful to highlight the areas where there's geographic atrophy. More slides of kind of macular degeneration and atrophy, and these are kind of tubulations which connotate cone cells, but it's just kind of this chronicity and changes there. So wet macular degeneration, this is what you would see in a patient who usually has acute vision loss. You may see signs of hemorrhage on exam and on OCT, which is super helpful for oxidative macular degeneration. And there's great studies that show that fluorescein is about as equivalent as OCT in initially diagnosing macular degeneration when it's exudative. So it's super helpful. And when you see fluid here, that's not supposed to be there, and that's probably from a leaky vessel for the most part when you see these patients. And here's that actual CNVM is probably somewhere in either here or somewhere in this area where there's a PED. And this is that area of exudation. This is a large serous PED with subretinal fluid there and probably some hemorrhage over here as well. And this is a large disciform scar from a regressed choroidal neovascular membrane. You can see here, this is all where that fibrosed PED is now left behind. There's no exudation still, but it's left behind a really big scar, and this patient has very poor vision because of that. This is a patient who I saw a couple months ago. She was getting Lucentis injections 20/20 in both eyes after we had got her stabilized. And 2 weeks after an injection, she's on blood thinners and she's elderly. She developed this massive subretinal hemorrhage and went to count fingers vision from 20/20. So kind of a tough situation. What do? Do you just continue with injections? Do you do something more aggressive? And so we opted to do a more aggressive approach to try to preserve vision with something called subretinal TPA. Let me see if this is going to probably have to exit out of here. Show you this video. This is the one video that's not mine, so I apologize. The video was not working at the hospital in the 2 cases I've done for this. So, but I'll show you this video if it works. There we go. So TPA is clot buster. I mean, that's what you use for a stroke if you're trying to break a clot. And you can actually inject it underneath the retina to break up that blood clot. This video is not fantastic, but you'll get the general idea here. So they're doing a vitrectomy. There was a breakthrough hemorrhage, so they're removing all that blood. And this is a Dr. Tamer Mahmood who kind of came up with this protocol for having to treat these. You use a very, very small cannula, 41 gauge cannula, so it's really, really tiny. And you actually penetrate the retina and inject the TPA underneath the retina, and this is that large blood clot. You also inject air as well underneath the retina. I know it sounds crazy. You inject air underneath the retina, and then you do a partial fluid air exchange, and you put a gas bubble inside of the vitreous cavity. And so, not a super common surgery. And it's kind of cool here. So this is kind of the principle behind this technique. So here's the blood. It used to be here. Blood is toxic to the outer retina. If you leave the blood there, this patient probably would have maintained maybe 2400, probably more like count fingers vision with that large of a hemorrhage. And so the blood was here. The TPA or clot buster liquefies it, so it's mobile. The air underneath the retina, which is this part here, helps to keep the fovea from having blood migrate back into it. And then the gas bubble we put in the eye, I'll show you the next slide here. This is post-op day 1, the same patient. The gas bubble then helps keep the air bubble from rising. Air would go up, and so if we didn't have this gas bubble, the air would just kind of go up to the top part of the eye. So this is kind of acting to sandwich the blood and then push it out inferiorly. And so there's actually blood down here on post-op day 1 in the inferior retina. You can see how big of a change this was post-op day 1 from pre-op. And so most of that blood is gone just on day 1. And then this is the macula post-op month 1. All the hemorrhage is gone. If you remember from back here, this was the hemorrhage before. And so all that blood's gone now. The outer retina is pretty good. I mean, it's not terrible. And, this was her month 1 as well. Pretty much most of the blood's gone now. And, vision's 2150. We'll see what she ends up getting to, but still optimistic that she's going to get some more vision back. But honestly, without doing this, you would have had a pretty poor outcome, so I'm happy with that. I'm probably going to start running out of time, so I'm going to go faster here, so I apologize. I don't know where we are here time-wise. So this is a CRVO. We're going to talk about retinal ischemia. This is a pretty classic where you have cotton wool spots, a bunch of hemorrhage, tortuous vessels, dilated optic nerve, and then that classic cystoid macular edema. And this is kind of pre and then post injections. You kind of notice out here too, do you see how the retina kind of tapers off? We just don't have as much thickness as we do over here. It kind of tapers off there. And you'll see that in patients who have retinal ischemic issues. They get temporal retinal atrophy. And so it's super common, something to hone in on when you see that. They probably had an old vein occlusion or less likely an artery occlusion, but often you'll see that with old vein occlusions. This is a patient who presented with inferior sectoral vision loss. You can see here that classic ischemic kind of white edematous looking macula. And this is what you should really be looking for with artery occlusions. This is not supposed to be that white and edematous. And it's kind of on the spectrum of PAM or paracentral acute middle maculopathy, where they get this edematous, not fluid, and it's not cystoid spaces, but edematous looking retina that correlates with these white changes. And you can actually see the plaque on this patient as well. And this is another example. This is actually an interesting case of I think a COVID-associated RAO with an RVO, so kind of a combo, and a really healthy 37-year-old person, so the prime of their life, I like to tell myself that. But he's super healthy dude and had this really bad vessel response and likely a COVID-related reaction. But you can see how much different the two retinas look. And this edematous kind of, it all looks white and schmutzy, and we're not having clear laminations there. And so the reason that's important is because the American Academy of Ophthalmology has really been pushing that artery occlusions are no longer just a retina problem. And really the comprehensive ophthalmologist should be trying to pick up on these things, understanding what they are and understanding the ramifications of that. So there's a relatively high correlation between an artery occlusion and a stroke. And so the current recommendations, and I can send this to all of you guys. So I made this for our practice, and this is kind of the protocol that they should be using and the workup they should be using. So I'm happy to email this to all of you, and I didn't just include it and then like switch a slide and be like, just kidding. But we'll send it to you. That's fine. But if you're not comfortable with the diagnosis, they should be evaluated urgently and seen for evaluation. If you're comfortable with the diagnosis and you know it's an artery occlusion, they need to go to the ER. And that's kind of the current protocol and the current recommendations. If it's a chronic artery occlusion, and most people use 14 days as a cutoff, so if it's been going on for a month, they probably don't need an urgent neuroimaging and carotid echo. But if it's been going on recently, they should have an urgent visit. I send these people straight to the ER. I've kind of mapped out which ERs have a stroke team, because that's also important. You'll send a patient to the ER and you'll get a call back and like, why the hell are you sending this patient here? This is an eye problem. But some people do or do not know the current literature and understand that this is an acute stroke until proven otherwise. So really important. Obviously, if you need help, just send them to us. We're happy to see them. But if you feel comfortable and you know it's an artery occlusion, they need to go to the emergency department. And this is what I was talking about, that atrophy. You can just see how pronounced that temporal loss is. And this is a patient who, another patient I'm treating with injections now. Their fluid's gone and they're doing great at 12 weeks, but she just has this persistent atrophy out here. Luckily, pretty good preserved vision because that outer retina is intact. So this is kind of things that may or may not have heard of. This is called PAM, or paracentral acute middle maculopathy. And you can see that internuclear layer just has this hyperreflectance. And this is ischemia at the middle or deep capillary plexus. And it's really a spectrum of an artery occlusion. There's not good clinical information at this point to say this patient needs an urgent stroke workup, and I typically don't do that because there's no data to support that decision. But this is really on the spectrum. It's just a much smaller vessel that's being occluded. And so these patients, I typically send to their primary care doctor and have them do a vascular workup and to make sure that their blood pressure, cholesterol is under control. And if they have high cholesterol, and work up further and potentially get neuroimaging depending on symptoms and how high risk they are. This is a different patient population. PAM is more in an elderly population who would have cholesterol, hypertension, diabetes, more vascular risk factors, where acute macular neuroretinopathy is in a younger patient population They often present with scotomas, which can be central or paracentral. On exam, you might see this kind of reddish brown lesions in the macula. And then it's really an outer retinal change here. And it's in that watershed zone between the choriocapillaris and where the retinal vasculature kind of meets. And it's kind of that middle ground. And so it's probably some sort of vascular spasms, vascular ischemic event, and there's often association with oral contraceptive pills as well. So subretinal fluid, I'm going to kind of be going into a couple other changes here when it comes to more acute pathology as well, but pachychoroidopathies is a word that I like to put in my notes a lot just because it makes me sound smart, but it's really just, pachy just means thick. Choroid is just the choriocapillaris. So it sounds cool, but it's really just thick choroid syndromes. So there's a different sets of pathologies that we found that are associated with thick choriocapillaris. The most common one that we've all seen is central serous chorioretinopathy. But there's also other things like pachychoroid pigment epitheliopathy, there's pachychoroid choroidal neovascular membranes, and then there's also polypoidal, which is a subset of wet macular degeneration, kind of falls into that same subset. So this is a patient with kind of normal choriocapillaris for somebody who's in their teens or early 20s. I kind of use a poor man's version where I take the retina, kind of put my thumb up to it, and put it next to the choriocapillaris. It looks about the same. It's probably normal. That's not very scientific, but that's usually helpful. But here you can see it's about double the thickness of the retina here. So this is a pretty thick choriocapillaris. Doesn't mean there's pathology, it just means it's a thick choriocapillaris. This is a young patient who I'm seeing for HLA-B27 associated uveitis, and he's got these changes here. So you'll see this kind of hypopigmented lesions here. This is his PSC cataract from steroids. But hypopigmented changes here, totally incidental, but he's got relatively thick choroid, and then these RPE elevations. It's not drusen, he's not 65 or older or even close, and so this is actually pachychoroid pigment epitheliopathy, which again is kind of an interesting finding. And I think a lot of times patients get classified as AMD when they actually have pachychoroid pigment epitheliopathy. But again, these can develop choroidal neovascular membranes, but pretty atypical for that to happen. This is a patient who I treated recently who has chronic central serous chorioretinopathy. Here's pachychoroid syndrome, very thick choriocapillaris, a little PED there. And then this subretinal fluid. You'll also see here, do you see how there's kind of this like shagginess to the outer retina? That connotates chronicity. And whenever I see that, I often reach for treatment earlier. You know, you can watch central serous, make sure they don't have any risk factors like high stress lifestyles or type A personalities, steroids, always ask about Flonase, topical creams, ointments, oral steroids, injections, and also sleep apnea too. So when you pull on their eyelids and it like jumps off their face, they probably have sleep apnea. And so sleep apnea is also a known association with central serous. So one of the things I kind of incorporate into my questions. But this patient got PDT, photodynamic therapy, and had a really excellent result and resolution of their subretinal fluid, and now they can proceed with their cataract surgery. This is, again, more subretinal fluid and wet AMD, and the reason I put this slide in here is just to see how thin this choriocapillaris is there. It's like super thin in comparison to the other patients we were showing you there. And this is what you would typically see in someone who's 75 or older who has wet macular degeneration. So this is a patient who comes into your office, has changes, get an Optimap, doesn't look normal. One thing here with macular attachments, just kind of want to run a few things here. So this is also subretinal fluid. This is an inferior detachment. And the question is, what's going on here? Is this MAC on, MAC off? And is this an acute or a chronic process? One thing you can see here, there's the PVD right there. That's the vitreous that's separated. But it's kind of hard to tell from the photo if this is MAC on or MAC off. So again, OCT is super helpful to know if it's MAC on or MAC off. This patient's MAC off. But on exam, you might not be able to pick that up. That fluid's pretty low. And so this is clearly MAC off. It's chronic because you can see that edematous, kind of swollen outer retina. And this is a chronic, I don't know why, this is a typo. Acute, probably MAC, acute symptoms, but this is chronic based on those photos. So just try to pretend like that's not there. But the OCT is helpful, right? Because if you just saw this patient, their vision was reasonable or symmetric, you might say, oh, this is a MAC on attachment. OCT is super helpful. Now, sometimes it's so bullish you can't get an OCT. But what does this also tell me? It tells me there's a PVD. I don't see the hyaloid anymore. It tells me it's also probably chronic because of this epiretinal membrane. So a lot of these things help you know chronicity. Is this an acute, somebody who needs surgery right away, or can it wait a couple days? But the PVD is also helpful to know because I think it's sometimes difficult with younger patients. We're trying to decide, is this an acute process or a chronic process? And again, the PVD helps. If there's an attached hyaloid, it's probably not a sudden change. It's probably a chronic, slow degenerative process. This patient had surgery, did very well, and now you can see that their fluid is gone and their retina is now attached. But I use, the other question might come up is what's MAC off and what's MAC on? If there's any fluid in the macula, is that MAC off? I think most people would use the fovea as your designation of MAC on or MAC off. So the fovea is detached or involved or split, we would consider that fovea off, retinal detachment, or MAC off. So this is a patient who we saw who just there for a routine exam, young 30-year-old who's coming in for glasses update, history of PRK, and looks, I don't know, if you just kind of buzz through this photo, it looks pretty normal. Hyaloid's attached. Macula looks pretty good. But then when you look at the autofluorescence, you're like, oh, what's that? That's fluid. So she's got a detachment. And if you look at the OCT at the bottom here, she's got subretinal fluid at the bottom of her macula. So she has a retinal detachment. She had no symptoms. The hyaloid's attached. This has probably been there for a very long time. But as the gel separates from that equator of the eye, it will separate there before it separates out the back of the eye, and then fluid's allowed to accumulate. If no one lived past 15, they probably never have a visually significant retinal detachment because the gel acts as its own tamponade in holding the retina in place. And so this patient, has anyone seen a scleral buckle before? Well, you will now. So this is a scleral buckle. So this is we prep the eye after we're doing a retromolar block. This is from fellowship and had like a camera crew with us. It was kind of cool. So you do a peritomy, remove all the conjunctiva. Dr. Sheth is back there just cringing. What are the retina people doing to my conj? You hook all the muscles. You tag them with a silk suture. You then do cryo to all the breaks. You then feed a silicone band around the eye. You then put a sleeve around it to hold it in place. Am I getting the axe? I'm almost done. I'm almost done. I'd keep talking forever, but. And then you suture down the buckle. I show this because it's like the one surgery we do that's like kind of gnarly, It's like, feels like you're like doing big surgery. So then we do a sclerotomy, cauterize that. And this is actually draining the subretinal fluid. So we're removing the subretinal fluid externally. You kind of pop a hole through the back of the eye and you're in the subretinal space from the outside of the eye. It's kind of gnarly. And then you kind of milk that fluid out. And that's the subretinal fluid. So and then you close up. So you kind of close all your wounds, take the silk out, give them some numbing medication, antibiotics, close the conj. You're all done. So this is the patient post-op. You can see the buccal indentation here. And they're attached now. And this is that same area where there was fluid before and it's gone. Sometimes the fluid, though, can take 6 months to a year for the fluid to go away if you don't drain. Even if you drain, sometimes there's some residual fluid. And that's okay. As long as the brakes are supported, the fluid will eventually be pumped out by the RPE. So that's it, Dr. Canoff. I'm done. Sorry. So if you have questions, always reach out. I have people just send me like a photo of an OCT and be like, what do you think? That's okay. OCT is great. Just try to correlate where it is you're seeing changes. Do those changes matter, and do we need to do anything about those changes? I think that's the biggest thing. Determining is it the outer retina or the inner retina is super helpful for OCT, because outer retina is going to be much more visually significant than the inner retina. Doesn't mean that both can't be problematic, but just trying to determine where is the pathology and do we need to do anything about it, and always correlate that with patient symptoms. If someone's coming in for a routine exam and they're 20/20 and super happy, maybe those changes aren't going to be as significant as someone who has an acute problem. So thanks so much for your attention. Hope you enjoyed, and all done. Do you want the? Yeah. Yeah.
Carl, just to clarify, in the setting of a situation where a patient calls up on the phone, sudden onset, loss of vision, they hustle themselves in the office, and you diagnose essential web heart occlusion, before you would ship them off to the emergency room for neuroimaging, what would you do for them on a daily basis to try and preserve any vision?
That's a very loaded question.
Okay, but beyond a 30-second comment.
There's no clinical data to support that anything you would do is going to improve their vision. There are some very small studies that looked at doing injections for patients to try to break up a clot with TPA. None of that data is very convincing. So the answer is nothing. I guess you can give them a bag and have them breathe in their bag or push on their eye, but none of that's been proven to be helpful. So,
I mean, really the whole thing at that point is just trying to prevent them from having a stroke. The whole point of going to the emergency room is not treating what's happening in the eye. What's happened in the eye has happened, and unfortunately, there's nothing we can do about that. But was it like within the next month, the data showed there's like a 10 or 15% risk of stroke. Yeah, 15% risk of stroke. So really, that's why the recommendations have changed, is that you're trying to prevent them from having that stroke that's going to happen. So yeah.
That's been a big push from the academy to get everyone on board with being able to diagnose an RAO, a retinal artery occlusion. That's the big push.
All right, great. So we'll take just a quick break if people want to refresh coffee, and then hopefully, is this working for people on their screen? It's big enough? Perfect. Okay, great. And in case you need it up close and personal, Priscilla has it. And then we'll switch to cornea in just a second, and we're going to try to educate Dr. Noble about what the cornea is. Okay, we'll move on to the next presentation to keep everything on time. So our next presentation is going to be from Dr. Amy Werner. She's our cornea and refractive surgeon. She is actually on a trip right now, so she can't be here, but we pre-recorded. And so it should be an interesting talk about corneal transplants. And then if any questions come up, we can try to answer some questions, but then also Priscilla was going to collect some questions, and we can then send them to Dr. Werner, and then she can email you guys back if there's other sort of questions. So we'll go ahead in just a sec.
Not being there, I have no financial disclosures. So I overcommitted myself and am actually going to be in South Carolina this weekend after 2.5 long years of pandemic. Don't know how many more football games we will go with my dad and when the next global pandemic may or may not occur. So he is a diehard Gamecocks football fan. I don't know why. They're not particularly good, but the games are very fun. So I'll see you at the next CE event in person, hopefully. So the last talk that I gave was about ocular surface squamous neoplasia. And I just want to show some pictures of the cases I've seen over the last year. This condition ranges from about 0.03 to 2 cases per 100,000 per year. So pretty rare, but I gave this talk and I'd seen it on occasion in the prior years, but the past year I've seen probably about 5 or 6 cases. So these are some of the cases that I've operated on this past year. All the patients are doing well after the surgery and topical interferon drops. So thank you for trusting me with your patients. So in outline, I'm going to talk a little bit about eye banking, which I think is fascinating, and then about indications for keratoplasty, a few specifics on certain diseases. And then I'll probably coast pretty quickly through PKP and DSEC so I can talk about my absolute favorite, which is DMEC, and show a surgical video of the procedure. So eye banking, eye donation is the most commonly donated tissue. There are over 80,000 people worldwide receiving transplant each year. Every 7 minutes, someone receives a corneal transplant, and over 2 million people have had their sight restored via keratoplasty. So the large overseeing body is the Eye Bank Association of America. It's the world's oldest transplant association. And they are responsible for accrediting eye banks and setting standards. They oversee the accreditation of these eye banks, and they provide more than 85,000 sight restoring corneas each year, and an additional 23,000 for education and research purposes. So some of their roles: they set up medical standards, they formalized and standardized eye banking procedures. They have medical standards, again, which are updated about twice a year by the American Academy of Ophthalmology. They have an accreditation program for eye banks, and they certify eye bank technicians, and they're responsible for keeping track of adverse reactions. They perform site visits for the eye banks, which are both announced and unannounced. So history of eye banking: the first transplant was performed in 1905 in what is now the Czech Republic by Dr. Firm. The first recipient was, I don't know how to say this, Alois Golgar, and he had, unfortunately, an alkali injury the year prior, making him blind from a corneal scar. The first donor was an unfortunate 11-year-old who had an injury with steel to both eyes. So evidently the injury didn't totally destroy his corneas, but he had to have his eyes enucleated. And then the ophthalmologist was able to harvest about a 5 millimeter graft from each eye, which was transplanted into the recipient. So one graft pretty much immediately failed, and the other one was seeing about 2,200 6 months later, which allowed this gentleman to return to work. The next notable surgeon popularized cadaveric donors. So he was Vladimir Vilotov. He's a Russian ophthalmologist, and he performed more than 3,500 transplants in his career. So he placed the corneas in moist jars and refrigerated them prior to use. The first transplant in the US was in 1937 by Dr. Patton. All these surgeons did their transplants without a surgical microscope, with relatively thick sutures. This ophthalmologist started the first eye bank in New York State. So up until the mid 20th century, penetrating keratoplasty was really a surgery of last resort. Since then, technology has improved due to surgical instrumentation, microscope, suture, understanding of endothelial function, and having media to preserve the tissue in for multiple days instead of 48 hours. And now we have better understanding of anti-inflammatory agents, ocular surface disease, and better surgical training and techniques. So cornea transplants were performed using corneas from living donors until about the 1930s. So like the first transplant, the corneas were removed from enucleated eyes and transplanted immediately. And even when cadaveric tissue was used, it was generally used within 24 to 36 hours post-mortem. After that, the endothelial viability significantly decreased. And then again, 1944, the first eye bank was established by Dr. Patton in New York. So old eye banks, they had a really long waiting list and waiting time. They could only keep corneas for a few days, and they distributed them to local ophthalmologists. So from 1945 to 1970, the ability to store corneas led to the establishment of more eye banks. So at this point in 1956, there were 7 eye banks that were operational. There was an eye bank committee formed by the American Academy of Ophthalmology. This is about the time period that the EBAA was formed. And there were a national network of ham radio operators that would coordinate transplants at that time. The demand still far exceeded supply. And then in 1968, the Congress passed the Uniform Anatomical Gift Act, allowing people to designate themselves as organ donors on their ID driver's license. So from 1971 to 1999, several things happened that greatly advanced eye banking. So there was the first storage medium, which was the McCary-Kaufman tissue transport medium, which allowed storage up to 4 days. The next iteration was Opticell GS, which is what we still use, and this allows preservation times out to 14 days. In Europe, they use organ culture media, which is not refrigerated media, it's warm tissue storage, and this is much more costly, but works quite well. Around this time, eye banks were professionalized. They were now under the EBA medical standards. Specular microscopes in eye banks led to better evaluation for tissue viability, and there were a lot of new laws and regulations put forth. Around this time, Medicare reimbursement was made available for recovery, preservation, and distribution fees. This followed along shortly after kidney transplantation. Eye banks used to be 100% privately funded, and around this time, they were able to get about 75% of their operating expenses from third-party insurance programs. And about 10 years after the EBA, the FDA started to regulate eye banks and all organ procurement agencies as well. So now we're lucky that supply greatly exceeds demand. Not only do we have enough transplants to take care of the patients in the US, and we're not, carrying a beeper to wake up in the middle of the night to go in to do a transplant, but we're also able to export 35,000 corneas to other countries without as good of infrastructure as ours for site preserving, saving procedures. So a lot of stuff happened between 1937 to 1998, cornea preservation medium, and then donation programs leading to a huge uptick in supply of donated tissue. Quality assurance and safety greatly increased. There was implementation of surgical microscope and then improvements in suture and micro instrumentation. And since that time, the tissue just keeps getting thinner with the advent of endothelial keratoplasty, DSEC, DMEC, et cetera. So details behind eye banking. So it starts with donation. Something I ran into that I thought was quite interesting was that Colorado and Wyoming have the highest percentage of the adult population registered to be a donor. So people being designated as donors greatly increased with the Uniform Anatomical Gift Act in 1998. If the patient's not registered, then the next of kin is then contacted to make the patient's wishes known to the best of the next of kin's knowledge. So there's a call center that's available 24/7. This call center takes calls from hospitals about potential donors, and then pre-screening takes place as far as gathering facts from the hospital to determine suitability of the patient for corneal donation. And then depending on their eligibility, a separate person is dispatched for retrieval and recovery of the corneas. So the goal of this is to be as fast as possible. So again, there's someone on call 24/7. The nationwide goal is to recover corneas within 8 hours from death. So the eye bank technician goes to the hospital, they do a physical assessment, they're looking for evidence of high-risk behaviors, any track marks that would identify IV drug use or thrush, open wounds, tattoos. They come with their own set of sterile equipment, surgical drapes to get the donor tissue. And then following recovery, the corneas are placed in media and refrigerated at 2 to 8 degrees Celsius until needed for transplantation. So during the screening process, there's serologies drawn, testing for multiple communicable diseases, HIV-1, HIV-2, hepatitis B, C. And these are generally exclusionary criteria for donating tissue for transplantation purposes, not necessarily for research. The iBank technician, once the tissue is received at the iBank, they do assessment of the suitability of the tissue for transplantation, looking at the specular microscope and getting the endothelial cell density. And then tissue is offered to the surgeon, who ultimately makes the final decision on whether to accept the tissue. So it's different, different surgeons have different criteria. Some have had a bad experience with patients that were on a ventilator, and they no longer accept tissue from patients on a ventilator. Personally, I've turned down some tissue with a history of herpes zoster ophthalmicus, although it's not active. I just deal with that on a daily basis too much to think about the virus reactivating in the recipient. Other exclusionary criteria, in addition to the serologies, so they did have some positive transmission of like a prion disease in one case, and maybe 1 or 2 cases of rabies in the early 70s. So for good reasons, viral encephalitis, bacterial encephalitis, or any progressive encephalopathy or dementia pretty much exclude someone from donating their cornea for transplantation. Down syndrome is a notable exclusion just for penetrating keratoplasty, presumably because Down syndrome patients are more likely to develop keratoconus. Refractive surgery is an exclusion criteria for PKP, but these patients may be candidates for endothelial keratoplasty donation, depending on their endothelial cell count. So these are some pictures of the equipment employed in the iBank. So on the bottom right, that is generally what the cornea buttons come in. So the endothelium is right side up with the little button facing down in the medium. On the left, you can see obviously it's a slit lamp microscope, and there's a little device that helps to clip the storage media so that the iBank technician can look at the cornea to see how much epithelial sloughing there is, the endothelial cell morphology, and they can also get specular microscopy on these. So storage media used now is Opticell GS. GS stands for streptomycin and gentamicin, so the tissue is kept in antibiotics. Recently, in the last 4 years, iBanks have done studies on adding amphotericin B to the storage media with more endothelial keratoplasty being performed. Basically, that iBanks have started taking over the preparation of this tissue. So they take the tissue from the 2 to 8 degrees Celsius and warm it up for a number of minutes before they process the tissue and cut the lenticule of the DSEC or strip the DMEC for implantation. So the rate of fungal keratitis, while it's very, very low, there are case reports of this happening after endothelial keratoplasty, more than penetrating keratoplasty. So this was a big concern for transplant surgeons, and there was good evidence that amphotericin B decreased the rate of positive fungal cultures, as well as, didn't affect the endothelial cell viability. So iBanks were kind of behind a lot of these big studies on the amphotericin B. They are behind a lot of the new ideas behind preloaded tissue, where you can, the tissue comes preloaded and stripped and ready to go for endothelial keratoplasty. So lots of innovation. Maybe one day in the not too distant future, maybe in my lifetime, we'll be able to culture corneal endothelium and implant it that way. So there's also some research on that front. So word on tissue selection. There are so many factors, death to preservation time, like when did the patient die? Was their body cooled? When was the tissue acquired? What was the age of the patient? All these factors that the eye banks have looked at to see if rates of success are higher in certain situations than others. A notable study is the cornea donor study, which has 10-year follow-up results. And basically the main objective of this study was to see if younger donors, if the recipients fared better than having older donors. And there was basically no impact shown on the 10-year success rate between these two groups. There were some differences in the extreme of age, but really 75% of corneas available are between 34 to 71 years. So age didn't really matter all that much. And interestingly, specifically for DMEC, or the thinnest type of cornea transplant, you actually want the patient to be ideally 65 because it makes the tissue less springy and easier to deal with. There was also a study, the death to preservation time study, and there were really no differences between tissues that were recovered right away and those that had a death to preservation time greater than 12 hours. The endothelial cell density was better for refrigerated corneas. So not a whole lot matters. Method of retrieval didn't matter. Processing factors didn't matter. Timing of donor cornea use didn't matter for success rate. And ABO incompatibility also did not affect success rate. One thing that the cornea donor study did find was that the endothelial cell density was higher over 5 years with larger grafts, younger donor age, and female donors, but there was a questionable significance of this. So onwards and upwards to keratoplasty. So always reminds me of alphabet soup with just all the letters mixed up. So on the left is a picture of a beautiful penetrating keratoplasty with a running suture with a few interrupted sutures. Bottom right is a picture representation of the different types of transplants and the tissue that is being transplanted into the recipient. So indications, so there are optical indications. Keratoconus is a big one, corneal scarring, therapeutic for Fuchs dystrophy, bullous keratopathy, eye syndrome. And then I also see endothelial failure from viral etiologies. There can be tectonic grafts. I've had, patients that have had corneal perforations that didn't seal up with gluing the cornea that ultimately went on to need a tectonic graft. There's our keratoconic eyeball. And that's an example of pseudophakic bullous keratopathy. So keratoconus, we all know very, very well. Irregular astigmatism is caused by progressive thinning and steepening. I have these patients try RGPs first because, hopefully we can get them to avoid surgery. Scleral contact lenses have gotten better and better, more comfortable, better tolerated. So the longer we can get these patients to avoid surgery or potentially not need surgery, the better. And then if they do go on to needing a PKP or a keratoplasty, always try DALK if possible. And I'll talk more about that in a little bit. And then I harass my patients to not rub their eyes because they go home and rub their eyes. So I had a patient last week with horrible eye drops. This is a picture on the bottom left. She's actually been dealing with this for about a month now. So not an indication, emergent indication for penetrating keratoplasty. We give these patients time to clear their corneas and see what kind of scarring they're left with and if they'll get a meaningful visual acuity with the amount of scarring left. The patient I saw the other week had this hyperpigmentation on the bridge of their nose. which is a finding that I've never really thought much about before, but patients with really bad allergies that tend to like rub their nose get this either hyperpigmentation or hypopigmentation right there in the nasal crease. Despite how many times, we tell patients not to rub their eyes, they definitely do. I had a cross-linking patient post cross-linking come in probably about 6 months later with eye drops, despite, repeatedly telling them, doesn't matter what we do, we can transplant you, we can do cross-linking, we can do Intacs, we can do whatever. If you continue to rub your eyes, you will get worse. So any talk about keratoconus deserves at least a mention of cross-linking. So the goal is to, obviously minimize the amount of transplants we have to do in these young patients that have a lifetime to live and potentially multiple transplants to face if they start out very early. So we're all waiting with bated breath for epithelial on cross-linking. The results of the phase 3 trial were very favorable, potentially some FDA approval in 2023 or 2024. So it's an accelerated protocol. So it's a little bit faster. It's epithelial on, so no epithelial debridement required. And there are these little oxygen goggles that patients wear around their eyes that helps increase the relative concentration of oxygen for the procedure. There's also some buzz about potentially a drop that may be available sometime in the distant future. The drop activates the lysyl oxidase enzyme, which boosts collagen cross-linking. And there are some studies that show there's decreased activity of this enzyme in corneas of patients with keratoconus. So another indication would be corneal scarring or opacity. Just like keratoconus, I recommend the patient try scleral contact lenses, RGPs first to see how much visual improvement they can get without a surgery, and then PKP if needed. As long as the patient hasn't had, any perforation in Descemet's membrane, and the endothelium looks okay. I always talk about DALK if possible, and I'm always careful in these patients to try to tease out if there's any history of HSV or HCV, because if the patients proceed with a transplant, they are committing to a lifetime of antivirals, oral antivirals. These conditions make them more likely to be neurotrophic, and that can also be a very difficult situation to encounter with transplants. Corneal perforation. So I had a patient who had a long-standing history of HSV and then perforated, glued her probably 3 times, but as soon as the glue came off, sometimes the glue works. If there's a really small perforation, the cornea kind of epithelializes underneath and the glue pops off and the patients do just fine. But every time the glue came off, she started leaking again. So she had a PKP. Indications for endothelial keratoplasty. So Fuchs dystrophy, we all know, is a issue with the endothelial cells. So average central corneal thickness is 540 microns. These endothelial cells are responsible for keeping the cornea the perfect water concentration in order to keep the collagen fibrils the right orientation so that the cornea remains transparent. So when the endothelial cells are low, the cornea reaches a tipping point where the tight junctions between the cells become compromised. There's not enough NAK ATPase pumps to pump the water out, and fluid enters the stroma. We're all losing these cells at an average of 0.6% per year, but those with Fuchs lose them faster. And even if they don't end up becoming edematous, sometimes these guttae and this beaten bronze appearance of the subendothelium can really limit the vision and cause really debilitating glare, requiring a transplant. So here's a picture of some endothelial cells with some scattered guttae. So Descemet's membrane thickens and develops these excrescences known as guttae. One clue that patients are reaching a tipping point is that they have morning blur for several hours. Yeah, I wake up and my vision's bad for about 4 hours, but then I'm able to kind of do the things I want to do. Another pearl is to compare the central corneal thickness to the peripheral corneal thickness, because in the periphery, it should be thicker than the center. So if you notice that the corneal central thickness is thicker than the periphery, then that can be a clue. 540 is the average, but some people have 600 microns cornea as baseline, and some people have, 480 micron cornea. So someone with a 480 micron cornea may be 540, but having significant and clinically significant edema, despite having a normal central corneal thickness. And some of these patients maintain surprisingly good Snellen visual acuity, but in the real world with glare, they're pretty incapacitated. Pseudophakic bullous keratopathy, so always explore the etiology. So was there a really difficult cataract case? Was the lens really dense? Is there vitreous in the anterior chamber? Because some of these end up being secondary corneal edema from things like retained lens fragments or in ACIOL, anterior chamber intraocular lens. So, also some patients, even if, they had glaucoma surgery and they have a tube and it's like beautiful, very well back from the cornea, but they might rub their eyes or like sleep on their stomach. And then you can see this little area of edema kind of emanating from where the tube is. Trauma, I had a patient here recently who had forceps delivery and known trauma to the eye and like some amblyopia, but they just now started to develop some edema where the Descemet's membrane was disrupted. There was a patient in residency who had an Ozurdex injected into the back of the eye, which is a steroid that the retina surgeons do, and it kind of migrated forward through loose sonules and disrupted the cornea. Interestingly, amantadine, which is a medication used for dementia, can cause secondary corneal edema. So I always ask my patients if they have a history of taking that. And then the etiology is not super clear. Again, look for lens fragments with a gonio lens to see if there's anything kind of running around the anterior chamber that's kind of banging against the endothelium at odd times. A history of a PPV with oil is also something to note. I had a patient who had endothelial failure, history of silicone oil in the back of the eye, and then the second surgery to remove it several years later. Brought the patient back for their surgery, and then they laid on their back and this little silicone oil bubble floated to the middle. And I was like, okay, yeah, that's what's causing the corneal edema. So this is one of my, one of the cases that taught me a lot. This gentleman, he had horrible corneal edema after cataract surgery a few years prior to meeting him, went back through the op report. The energy used during surgery wasn't very remarkable, nothing really remarkable about the surgery. The most I could come up with was maybe water was injected into the eye instead of what we usually use, which is balanced salt solution, and that can be kind of traumatic for the endothelial cells. But anyway, bottom line is he ended up getting a endothelial keratoplasty edemac. This is his result here on the bottom. Surgery went super great, beautiful, very well. He had a very hard time with a neurotrophic cornea afterwards with a giant epithelial defect. He had cell in the AC. And in retrospect, this patient had most likely endotheliitis from a viral etiology, because after putting him on Valtrex and steroids, he cleared up quite nicely, but it took a long time. Also, cornea transplant or PKP failure can be an indication for endothelial keratoplasty, especially if the patient has maintained pretty good vision in scleral contact lenses or glasses. There's no need to reinvent the wheel and go take out all those stitches and suture in a whole new full thickness graft. So this is an anterior segment OCT of one of my patients that I did a DSEC on, and you can kind of see the edge of the PKP there and the DSEC lenticule right at the edge of the PKP graft. So penetrating keratoplasty, I think we've probably seen a video on this, but essentially, you measure the area of the cornea that needs to be replaced. If there is a cone, you try to measure out the cone. If there's a scar, you measure out the scar, and then plan accordingly. I use a Floringa ring here, which is this steel or stainless steel circle here that helps the sclera maintain rigidity. You just kind of suture that on. So we trephinate the area that's abnormal, and then we oversize a graft by about a quarter millimeter and suture it in with 16 interrupted sutures. Some surgeons use a running suture. Studies have had conflicting results. Some studies say that the running suture is better for astigmatism. Some say that the 16 interrupted sutures are better. So it probably just comes down to the surgeon's training and experience. And I'm going to skip this video so we have time to watch other videos. So a word on DALK. So deep anterior lamellar keratoplasty, essentially you're keeping that inner layer of Descemet's membrane intact. So decreases the rate of rejection and endothelial rejection. And also it maintains kind of like a closed system during the surgery. You're not dealing with like this open sky where there's no cap on the cornea. And for trauma, these eyes are much more stable because I'm sure it's not very common, but we see a patient every few months that's had trauma and a dehiscence of their PKP graft. So I just want to show a video of how this is done. I think it's super slick. Might have to go back and go into YouTube, but essentially surgeons, they dissect down to 100 microns into the cornea with let's see, I want to be at about a minute. So they're taking off the anterior cap here. They've already trephinated down to like 90% depth of the cornea. And then a little cannula that has an opening on the back of the cannula is inserted. The goal is it to be about 100 microns away from the endothelium, and air is injected. And the air pushes Descemet's membrane down, stroma up, and that's how the surgeon dissects the cap away from Descemet's membrane. So here they're injecting viscoelastic between Descemet's membrane and the rest of the stroma. Similar to PKP, right and left cutting scissors are used. And then here is the donor cornea, and basically they're just going to strip off Descemet's membrane because Descemet's membrane is still on the recipient's eye. And then the surgeon does their thing and does their sutures. All right. So advantages, no positioning needed as opposed to endothelial keratoplasty. When possible, DALK, I think, is the superior option to PKP, even though it's much more technically challenging. But the worst that happens is you have to convert to a PKP if there's a rupture in Descemet's membrane. If you can imagine, I mean, Descemet's membrane, 10 microns. It's relatively common to have a perforation during the bubble technique and to have to convert to a PKP. There's less rejection with DALK, stronger globe. I had a patient who he had a penetrating keratoplasty many years ago, and then I did a DALK on him, and he had trauma to his face. I still haven't gotten the whole story, but the DALK eye did fine, and then the PKP eye had a dehiscence of the wound. So one of the biggest things that makes me nervous about penetrating keratoplasties is that there is that period where you're open sky and there's a risk for explosive hemorrhage, quite low, but still a devastating complication. Another disadvantage is the induced astigmatism from the sutures. There's definitely a higher rate of rejection at 5 years. Roughly about a quarter of the subjects had at least one rejection event, and 37% of these had graft failure due to the rejection event. So wound leaks can be a complication, glaucoma from the chronic steroid, need for chronic steroids, and then trauma creates complications. All right, so on to endothelial keratoplasty. So around 2006, endothelial keratoplasty really started to take off, and penetrating keratoplasty started to decline in numbers. And then 2012, endothelial keratoplasty surpassed, EK cases surpassed those of PKP cases. And endothelial keratoplasty is now considered the gold standard for treatment of endothelial pathologies. So many advantages of EK over PKP. So there's better functional outcomes, faster visual recovery. You don't have sutures that are being taken out for, a year. You have a closed globe during the surgery. You don't have suture complications where sutures are breaking randomly, and can lead to suture-related infectious keratitis. And then there's a huge decrease in rejection because you don't have the risk for endothelial rejection, stromal rejection, and epithelial rejection. It's just the endothelial rejection. So eye banks have been really helpful in the advancement and ease of these procedures, starting with preparing the DSEC tissue, preparing DMEC tissue. Then they started to come pre-punched, and now they come preloaded and ready for injection. There's a picture down here on the right of an S stamp showing how the donor cornea is flipped upside down and a little cap is taken off, and then a little stamp with an S is put on. So that way, when you inject the donor cornea into the eye, you can tell if it's upside down or right side up. A backwards S is not good. So DMEC is my favorite. So you can see here on the right upper corner, this is an eye that has an air bubble still left in it after a DMEC transplant, but you basically can't tell anything's done. You have to look pretty hard at the cornea, at the endothelium, to see the DMEC graft and the S stamp and where the Decimeter-Rexis has occurred. So really slick surgery, very beautiful results. And I love that the cornea goes back to looking like a pristine cornea. So in contrast to DSEC, DMEC is just the corneal endothelium and Decime's layer. So fantastic visual results at 6 months. The tissue is pretty hard to manipulate. It's 10 to 15 microns thick, so 4 times thinner than a sheet of paper. This little graph down here on the right side shows with an increasing number of DMEC cases, DSEC cases have been declining over the past 7 years or so. This video here, I'll probably skip it in the interest of time. But basically the donor cornea is flipped upside down and stained, and the eye bank basically separates Decime's membrane from the rest of the cornea and preloads it into this little cannula here on the bottom right. So this is how the tissue looks when it comes to us in the OR. We used to do all these steps on the left, including loading it into the injector. But, do this, twice a week compared to an eye bank technician who's doing it multiple times a day for, many, many surgeons. So not only there are advantages to surgery time being lower, but also probably less endothelial damage by someone who is doing this constantly. So indications for DMEC: any endothelial disease, Fuchs, pseudophakic bullous keratopathy, eye syndrome. So we will go on to a video. This is a video from, oops, okay, hold on, let's see. All right, so I might have to get out of here. Oh no, here it goes. This is a video from the University of Iowa. So a mark is made for the main incision. Paracentesis incisions are made, and then viscoelastic is injected into the eye after Myocol to make the pupil smaller. This patient happens to be phakic, so no cataract surgery yet. An LPI was created there inferiorly, preoperatively. That's to help prevent pupillary block, because as you'll see, a big giant air bubble is injected at the end of the case to help support the transplant. So here the surgeon is doing a Decimeter-Rexis, scoring, and removal of Decime's membrane. I usually use trypan blue during this part of the surgery to better visualize any tags that may be created. So scoring is done, and then usually surprisingly easily, Decime's membrane just peels right off. So being careful not to leave any tags or to press too firmly into the stroma, because you don't want any irregularities on the stromal bed that the DMEC will have trouble attaching to. main incisions made. So this is like, I think it was 3.4 millimeter incision to go with the Jones tube. That was a cannula for insertion. But now the cannulas have even gotten down to 2.4 millimeters. So same size as a cataract surgery incision. So here the surgeon's just making sure the Jones tube will fit into the incision. So this is a surgeon who's preparing his own tissue. So they're staining, the cornea is kind of upside down here, and they're staining endothelium. They're using scuba technique. So there's balanced salt solution, and they're kind of stripping the Descemet's membrane from the stroma under fluid. They stain it with trypan blue, makes this beautiful scroll, and then they load it into the injector. So super important to keep the anterior chamber really flat, which is pretty counterintuitive for us, but we've definitely seen the transplant fly out of the main wound if there's too much pressure inside the eye. It follows the path of least resistance. So the surgeon's maintaining a really shallow anterior chamber to give the transplant something to bounce against so that it can be opened up. And there are different ways to unfold the graft depending on what type of configuration it's in when it's injected. So pretty. And then they inject air underneath the transplant. Now with the 2.4 millimeter incision, it's relatively rare to need a tenno nylon to close the wound. So this surgeon is using SF6, which lasts for 5 days on average. Some surgeons, including myself, use air. Air has a lower likelihood of having an increased eye pressure in the early postoperative period, but it does get resorbed from the eye a bit sooner, about 3 to 4 days. So I tell the patients that the most important part of the surgery is not what I do, but it's what they do, and that's position, position, position. Patients teach me stuff all the time. I had a patient come in here recently with these prism glasses. They have to lay flat on their back and look at the ceiling so the air bubble floats up and supports the graft. So this patient has these glasses where they can lay flat and still watch their TV across the room. I've had patients come in with projectors for Netflix for the ceiling. So all sorts of stuff, but definitely beats my patient who had a perfect transplant. And then not only did he not position, but he went and got on a riding lawnmower and then came in about a month later with a detachment of the graft. So complications. So intraoperative complications, you can have ejection of the graft from inside of the anterior chamber. I've definitely seen that in training. You can have pupillary block from that really large air bubble that you leave in place. Graft detachment, at least partial, is very common, about 35%, but only about 6% of these people need extra air placed inside of the eye at some point. My general rule of thumb is 30% or more of the graft that's detached. I'll recommend a rebubble. But some of these people will say, no, I want to wait, and they'll still zipper up on their own. Primary graft failure is very low. Primary graft failure is where the cornea is injected or transplanted and it never attaches and the edema never really resolves. Secondary graft failure is a risk from trauma to the graft during surgery, or just a transplant that's been around for a long time and the endothelial cells have kind of stopped working. Infection is very rare, but there are a certain number of reports of fungal keratitis being transmitted to the recipient from the donor. And then rejection is quite low. It's about 2% at 8 years. But in general, if patients stay on topical steroids, their rate of rejection essentially goes down to 0%. And then ocular hypertension can be an issue from the chronic steroids. So at about a year, I try to transition these people to FML or loteprednol. And, occasionally if they're having pressure issues, we can stop steroids altogether. So it's kind of hard to see, but this bottom right picture, there's a central detachment right there with some edema that's accompanying that. And then the top picture is from a patient of mine, my only patient that I have had that's had primary graft failure. This is a picture of pupillary block from either an SF6 bubble or air that has migrated behind the pupil and is bringing the iris forward. But general, the laser peripheral iridotomy that you saw in the video is helpful for preventing that. So advantages to DMEC, it has the most rapid visual rehabilitation of any keratoplasty. Few or no sutures are placed. Final visual acuity can be outstanding. And because less tissue is transplanted, there's a lower risk of allograft rejection. And topical steroids discontinuation can be considered. And there's no large graft host junction, reducing the risk of dehiscence. There's a steep learning curve that's hard to work with, pretty relatively high rate of graft edge lifts that you don't encounter with DSEC, which is thicker. And then you have to have the right candidate. So complex anterior segments are not ideal for this technique, either because there's a tube and it's hard to keep air in there, or the patients had their posterior pars plana vitrectomy, and there's not a lot of posterior pressure to help make the shallow chamber and the tissue unfold. So my case of primary graft failure from a few weeks ago, we went back and retransplanted him. There are no guidelines by the EBA on whether you should culture the donor rim prior to transplantation. And in fact, for bacterial culture, it's kind of found to be very unhelpful because positive cultures don't correlate with infections whatsoever. But I still do fungal cultures on my patients. And interestingly, after I had done the second transplant, we removed this tissue that never woke up despite multiple rebubbles. We placed a second DMAC, and then about 2 weeks later, fungus takes longer to grow, but I got a positive fungal culture from the tissue that was originally placed despite the medium having amphotericin B in it. So he's doing okay now, but we'll have to watch him really closely for any signs of interface opacities that could signify that he's developing a fungal infection. And other things that you have to worry about would be altitude, the air bubble, which I didn't have to worry about in Florida, but it's definitely an issue here. So I'm going to cruise through DSEC so that we can finish and everyone can have a break and walk around. So DSEC ranges from 40 to 110 microns. There are multiple ways to inject the tissue. There's an endoserter, there are glides, and now they're even coming preloaded. So the A part of this, DSAEK, decimated stripping automated endothelial keratoplasty, refers to the fact that tissue isn't like manually done. It's done by a microkeratome. So similar to what used to be used for LASIK. There's a little artificial anterior chamber here, and a little microkeratome cuts off the cap, and what's left behind is the DSEC tissue. So this is made tissue much more widely available and uniform and easier to prepare. So same indications as for DMEC, plus a complex anterior chamber. Tissue is much easier to deal with. No real unfolding is involved. And generally the same steps. Positioning is also important, but if the graft is attached on day one, we're much more optimistic that it's going to stay attached and not have any edge lifts on the graft. So here is an example of an endoglide. The tissue is being loaded in the barrel there on the top, and then the bottom right, a little forceps is used to pull the graft into the anterior chamber. Very similar complications to DMEC. And then better for complex anterior segments, better for patients that can't position. I had a patient who mentioned to me after the fact that he has a really bad shoulder and can't lay flat on his back. So DSEC would have been a much better option for him than DMEC, and also better for people who live at altitude because the air bubble is not such a big deal. So it doesn't have to be as large, and you can make it smaller so it doesn't hang around for as long. So future of eye banking. So Interestingly, there were a few case reports of patients that had DMACs, and for whatever reason, they didn't attach, and the patient either got like really sick or they weren't interested in undergoing another transplant. And some of these corneas cleared. So there are some folks doing what we call a DWEC, decimeterexis without endothelial keratoplasty, or same thing as DSO, which is decimate stripping only. So stripping maybe like a 4 millimeter diameter area in the endothelium, and then using ROCK inhibitors, which is generally a glaucoma drop, to help promote endothelial migration and function. So some interesting case reports here. Oh, let me go back. So not a great option for a patient who's desiring really fast visual recovery. Some of these corneas don't clear and end up going on to need a DMAC, but definitely something interesting where, for however it happens, these endothelial cells, which we're taught, they don't migrate and they don't replace themselves, are kind of migrating to the center of the cornea and leading to a clear cornea. So any questions, I'm happy to answer. You can email me, you can call me. You can also let Priscilla know, and I'm happy to email back with any questions that are submitted.
Great. So why don't we just take a few-minute break? Priscilla has reminded me that the Glaukos people are feeling lonely. So we'll take a few-minute break, and then we'll get started in maybe just about 5 minutes and keep things moving. Thanks.
Hi, everyone. I just wanted to thank all of you for coming. And as you may or may not know, I'm Joel Myers. I do the oculofacial plastics in the group. And I'm nowhere near as overcommitted today as Dr. Werner was, but my wife will be pretty perturbed if I don't get home to help out, because in 2 hours we're having quite a number of people at our home to have a meal. So I did want to mention to you that if you are ever in need of quick curbside consultation, so to speak, or have a patient that you have concerns about or want to refer, just feel free to text me, and my phone number, Priscilla can give this to you later on if you don't write it down right now, but it's 303-775-6229. And there's a number of you in the group that I communicate with that way, with pictures of patients that we can quickly just go over real quick, so that if there's a question on whether they need to come in, get checked, have a biopsy or surgery or whatever. And also myself and my medical assistant can troubleshoot getting patients into the office a lot more quickly at times than you can do just by having them call up on the phone. So again, if you didn't write down the phone number, Priscilla can get it to you later, so thanks.
All right, so we'll go ahead and do the next talk, keep things moving. So Dr. Sheth is going to be giving the next talk on glaucoma, but just real quick before we do that talk, we just wanted to talk a little bit about our research. So one of the exciting things we've started over the last year and a half is a clinical research department. And we're really proud that the work we've done, and Dr. Manry has really been spearheading it, and he's just going to tell you a little bit about our current ongoing clinical trials. And it's really something exciting we can offer patients to be in these clinical studies now.
Hi, good morning. You guys can continue to mingle and be on break while I'm chit-chatting about this if you want. It's kind of a little bonus talk that we'll talk about. But yeah, so about a year and a half ago, we started a clinical research department at the eye care center. So started with one full-time person. We now have 2 full-time people, 1 part-time person that's working in our research department. In that year and a half, we've grown and are now currently conducting 7 clinical trials, which is pretty fast growth for a clinical research department. So I want to just kind of very briefly discuss a few of those, kind of let you know what things we're working on in the world of eye disease and where the future may be for treatments. So you can advance. You've already seen a lot of us, so we'll kind of just keep going through, but it's a separate department within the eye care center. We have an IRB that we use to make sure that the things we're doing are ethical and following the rules and regulations of conducting good quality research. We have dedicated equipment that we use for these visits, and then patients are compensated for their time. Also, some of them come from further away, and so that we can arrange transportation for those patients to be in the trial so that they don't even need to drive themselves. A car will come pick them up and then take them home when everything is all done. We are working on this to reduce the burden of treatment and the costs of patient for care, say in the retina world, moving away from monthly injections to other treatments that can get them away from that burden. Also, a lot of our diseases may continue to progress even with or without treatment, so trying to halt ongoing vision loss and in some cases restore vision with things like inherited retinal diseases. Go ahead and advance the next slide there. So we have 5 trials that we're actively enrolling for, and we will discuss these in more detail. And then 2 that are ongoing where we're collecting data still, but we're no longer enrolling any more patients. So a lot of our trials are working on wet AMD. So Opthea is a phase 3 trial, so that's the last phase before potential FDA approval. And it's looking at treating an anti-VEGF drug in combination with either Lucentis or Eylea to treat wet AMD. So if a lot of our diseases are targeting VEGF-A or VEGF-B, like Avastin, Lucentis, Eylea, or one of our newer drugs, Vabysmo, which is VEGF and Ang2, then there's other targets with VEGF-C or D. So if you try to block one pathway, sometimes the eye will upregulate VEGF-C and D. So we're looking at if we block VEGF-C and D, does that then reduce the treatment burden and get better outcomes for those patients. Unity UBX1325, we are investigating it both for wet AMD and diabetic macular edema. And basically what this drug is doing is causing what we call senescent cells, which are sick cells within the tissue that are releasing a lot of the growth factors or other factors that are driving disease forward. If you induce those cells to undergo apoptosis and basically die off, then you'll get a lot less of VEGF and other factors. And so that's what this drug is investigating. So we're looking at it both from a macular degeneration standpoint and a diabetic standpoint. You can just go to the next slide, and probably the next slide as well. So Alexion is looking at geographic atrophy. So this is been looked at a few times from a few ways, and it's very hard to treat this disease because it's such a slow ongoing process. But essentially a lot of the targets are looking at the complement pathway, which is an inflammatory cascade. And if you reduce the inflammation in macular degeneration, do you slow down the progression of the more advanced AMD with geographic atrophy? So danacopin is an oral medication. You can go ahead and advance to the next slide. And looking at blocking factor D in the complement pathway. It does cause patients to become a little bit immunosuppressed, so they have to be up to date on vaccinations and things like that. And then this is a slide I love with some sarcasm, but just basically going through the complement cascade and seeing all of the different targets that we have. So complement factor D is right there. And I'll talk very briefly about this kind of towards the end, but we can also look at, there's complement factor 3 a little bit further down. in the cascade, and that's another potential target that we may have for available treatment actually very soon. Regenx Bio is our newest trial that we've just added. This is one that I think we're most excited about. So RGX-314 is, this is gene therapy. So it's potentially a one-time treatment done by either surgery or suprachoroidal injection. Mostly looked at being treated for wet AMD, but also looking at diabetic retinopathy. But it's basically a subretinal injection of a viral vector that carries the signal for essentially Lucentis. And so it's basically teaching the RPE how to make its own Lucentis. What they're looking at is essentially if we do this, will the eye make its own anti-VEGF and we no longer need to do injections at all? So you can see here that there's an anti-VEGF gene that is injected into the subretinal space and then teaching the RPE to produce its own anti-VEGF. So this is pretty exciting. Another trial is an observational study. So how do we predict who is going to go on and develop more advanced macular degeneration, specifically either geographic atrophy or wet AMD? So these are patients that have more high-risk features like a lot of pigment and RPE clumping and large PEDs, and then following them more closely over time to see what, if anything, can be identified that's driving their disease forward. This is a study that we're about to wrap up recruitment for, but in the world outside of retina, also looking at varenicline, which is a nasal spray for the treatment of neurotrophic keratopathy, or NK. And so it's a acetylcholine receptor agonist, so it would work to block that and increase basal tear production. And then finally, just talking about new treatment that may potentially be coming soon, as we talked about the complement pathway. This is not one of our studies, but just something to look out for. It may have FDA approval in just a few months, but it's complement 3 inhibitors that are being developed by Apellis. It's an intravitreal injection, but is looking at slowing down progression of geographic atrophy. So if this gets FDA approval, then I think we'll kind of be talking more about this as a potential treatment for a disease that we really haven't had a treatment for, which is exciting. So Mariah is our main clinical research coordinator. Her contact information is up there. But also, if you guys have any questions about these studies, have any patients that you want more information for participating in the studies, and you can also feel free to talk to Priscilla or email me. It's just mmanry@eccnc.net. So thank you.
Hello, I am Dr. Sheth, Anjali Sheth. I do glaucoma. I know some of you, but not all of you, so thanks for coming. I'm going to kind of go over a review of secondary open-angle glaucoma. A lot of it's probably a review more than any new information, but I just thought it was good to review. And then if I say review again, please smack me. I just recently came back with Dr. Rothstein from a mission trip to Guatemala, so I have some videos from there as well that I was going to just show, and then photos at the end. So I have no financial disclosures, and so we all know that glaucoma is a progressive optic neuropathy with associated visual field defects. However, it's independent of eye pressure, so they can have a normal, low pressure, or very elevated, and that does not give us a diagnosis, just a pressure alone. It is the leading cause of blindness in people over 60, and there's multiple risk factors that we should be aware of, including family history, age, race, and geographic locations. And the only modifiable risk factor that we still have at this point is IOP control. So elevated eye pressure leads to the damage of the optic nerve with visual field defects, and over time, this will lead to permanent vision loss and blindness. And so we can prevent vision loss, but we can't cure it. And so the earlier detection is beneficial for these patients. And what I tell patients is that either your eye is making too much fluid or it's not draining it well enough, or there's an imbalance between these two mechanisms. And so in open angle, the angle looks normal, but it's just not functioning well, as opposed to the angle closure, narrow angle glaucoma. And so secondary open angle looks very similar to primary open angle glaucoma with elevated eye pressures, open angles, and associated disc and field changes, but there's some underlying disorder that's leading to alterations in the aqueous humor dynamics. And so you can break this up into pre-trabecular, trabecular, and post-trabecular causes. And so in pre-trabecular, for example, neovascular glaucoma, we see usually when it's already closed and it becomes a secondary closed angle glaucoma with PAS. But early on, if we can diagnose neovascularization, we can send them to retina to get avastin injections to get rid of this fibrovascular membrane that can grow and prevent needing a tube later down the road, potentially. You can get epithelial or fibrous downgrowth or inflammatory membranes. And then commonly, trabecular causes are from clogging, so like anahiphemas or trauma RBCs or inflammatory cases. You can get oil in the angle, neoplastic pigment dispersion can cause it, and then also just alteration of the actual trabecular meshwork. And this again could be from inflammatory causes, steroid-induced trauma, chemical injury. And then post-trabecular causes are more due to increased epivenous scleral pressure, and so this can be any obstruction. So thyroid eye disease, cavernous sinus thrombosis, Sturge-Weber can have elevated eye pressures for these reasons. And for every 1 millimeter of rise in epivenous scleral pressure, you can get anywhere from 0 to 8 millimeters rise in the IOP mercury rays. So first, I was just going to talk about pigmentary glaucoma. So pigmentary dispersion is the syndrome is before glaucoma develops, and so this can be often found on routine exam, and a quarter to a half of these patients will develop ocular hypertension or glaucoma down the road. 10% will convert at 5 years, and 15% will convert at 15 years. It's more common in men, usually 2 to 1, and it's usually younger age men that are myopic. It is there is an autosomal dominant gene locus, but it does not have to be. And so symptoms can be none at all, and then there's a lot of patients that if you question them further, they might have some blurring after like heavy exercise or strenuous activity. So some people recommend checking pressures 30 minutes before exercise and then 30 minutes after, just to see how much pigment is liberated, to see how wide of fluctuations that they're getting. And so it's generally bilateral, but it could be very asymmetric, and it's due to the pigment epithelium rubbing against the zonules, and then that depositing in the trabecular meshwork and clogging it, but also damaging the trabecular meshwork endothelial cells because of the phagocytosis of those cells and causing cell injury and death. And so some findings that are very typical are these transillumination defects. And so on retroillumination, you see this spoke-like effect. Let me see. And then, I'm not sure if you can see it that well on this, but this is the Krukenberg spindle. It's not pathognomonic for pigmentary dispersion, but you can see it in trauma and uveitis, but it's usually vertical due to the aqueous current, convection current, and the endothelial cells actually phagocytose the pigment and it gets embedded. So you can also see pigment on the iris surface, and then heterochromia and anisocoria if it's very asymmetric cases. And then this, I was going to talk about a little bit more in a couple slides, but this backbone configuration, which leads to a reverse pupillary block and more pigment release, is very typical. And this, people question whether a LPI would actually help, so I have a couple slides on that. And then Zettmeyer's ring or Shay's line is this deposition of pigment along where the zonule is attached to the equatorial line of the lens. Also, lattice degeneration, and there's a higher rate of retinal detachments and retinal tears in these patients. So treatment includes typically medications first. Miotics in theory should work, but we avoid those because it should help decrease the iridozonular touch and increase outflow, but there's a higher risk of RDs associated with high myopia, and these are the patients that typically have higher myopia, so it's not recommended. SLT, if you do this, it does work really well because the pigment uptakes very well into the, with SLT, but you want to use very low settings because there can be IOP spikes from this. And then since these patients are younger, I tend to start with angle-based surgery just because their outflow mechanisms are working well, they're just clogged. And so if you can remove with like a goniotomy a portion of the angle, it really helps the outflow. And if we do a more traditional surgery like trabeculectomy, they're more prone to overfiltration and maculopathy from low pressure. So you just want to be cognizant of that before taking them to a more aggressive surgery. So what I was talking about with the LPIs is what happens is in pigmentary dispersion, glaucoma, usually there's an equal gradient of pressure between the posterior and anterior iris, but in pigmentary dispersion, there's thought to be like a reverse pupillary block where the iris acts as this one-way valve that a higher pressure in the anterior portion pushes the iris down and backbows it against those zonules and then releases more pigment. And so the question is if doing an LPI would help reduce pigment shedding. And so generally it's controversial, and there are studies that come out about it that go back and forth whether it's helpful or not, but usually if it's a younger patient, it can potentially help before glaucoma develops in the syndrome, but not when the diagnosis is made. And so this is what I was trying to show in that earlier picture, this backbowing, and this is a UBM of the iris, just really concave versus this more typical configuration, and this is pre and post PI. I don't know, I had a link, I want to see if it'll work. This is a great website to look at different angle anatomy. Let me see if it'll work. No, hold on a sec. Sorry. Let's see. All right, well, I'll try to show it at the end if I can get it to work again. It was just kind of showing how this, after the compression of this changes after PI. But you can also see just with this light reflection of the beam, how it's flattened out. So there was a prospective controlled randomized study in 2011, and there have been some since then, looking at eyes that had dispersion syndrome without any glaucoma and randomizing them to whether a PI would help or not. Their primary outcome was looking at conversion at 3 years, and their secondary outcomes were whether they needed drops or had any visual field changes over the time. And so 6% of the treated group versus 15% of the the control group were started on medical treatment, but there was no difference to time of visual field progression or topical therapy. So really, I don't tend to do LPIs, and I don't think most people do unless it's like a younger patient that hasn't had a ton of pigment shedding already, because once it's already kind of shed a lot, there's going to be a burnout phase when they're older where there's not much more pigment to rub off. So doing the LPI is not really going to change the course of the glaucoma in those patients. Okay. So pseudoexfoliation glaucoma, this is actually seen a ton in Guatemala, but it is often older Scandinavian women. There is a gene mutation connection, and patients that have pseudoexfoliation have up to 40% risk of developing glaucoma over 10 years. So this is something that we want to catch as early and watch for because they have very large IOP fluctuations. And so this is a fibrillar material that's kind of made all over the body, but from a basement membrane disease, but it really affects the eyes. And so it causes obstruction, just like pigment does, and damage to the trabecular meshwork. It circulates in the aqueous, and then, like I said, you can have these very wide fluctuations, more than just primary open-angle glaucoma. And generally, they have no symptoms, just like glaucoma patients, primary open-angle glaucoma patients have no symptoms, but this can progress much more rapidly. And so these patients, you can see this like patchy pigmented line. It's not as densely pigmented always as pigmentary dispersion, but it's anterior to Schwabe's line, and it's called Sampelisi's line if you see it on gonioscopy. And then you can actually, it's kind of a cool picture, but you can see this along the zonules, the pseudoexfoliation material sitting on it. And so it causes weakness to the zonules, and so it's really important during surgery to be aware of it, because it won't let you dilate as well. It can shallow the anterior chamber, so we know that there's issues with the zonules in general, and you can have lens subluxation or dislocation. And then you can see some of the debris along the pupillary margin. You can have loss of the normal rough. And then this is a really great classic photo, but this bullseye configuration where there's this clearing zone just from pupillary movement. But when they're constricted, that's where the material's depositing, and then when their pupils dilate a little, that's where it's landing. And then they can have poor dilation. So this is due to the infiltration of the iris stroma with this extracellular matrix material. So it causes obstruction to the dilator muscle. And then marcelling, which is these, I had a video of this too, but I don't think it'll work. But these like dark and light pigmented lines that can form. So treatment, you want to be aware of IOP fluctuations. Medication is usually first line. SLT does work really well in these patients as well. And then for surgery, there are a lot of considerations because of the higher rate of complications. This is showing the anterior capsular phimosis that can happen later on after healing. And so usually trying to make a very wide rexus is helpful to prevent this. And then using a CTR or 3-piece IOL. So preoperative considerations are checking for the subluxation, phacodenesis, shallowing of the AC, how they dilate if they have glaucoma, and any zonular weakness. Intraoperative or similar zonular weakness and poor dilation. Some of these patients will need CTRs, segments, or intracaps if there's no support at all. And then postoperative considerations are watching for IOP spikes, capsular contraction, IOL dislocation, and edema. So this picture here is a traditional CTR. This is a CTR, a modified CTR with a segment with an eyelet, sorry. And then this is a Ahmed capsular tension segment, and this is a hook that we can use. And so the first two you can use when there's no tears on the anterior posterior capsular of the anterior posterior capsule, but you can't use those if there is, and then this you can. I don't typically use either of these. That's usually more cornea surgeons that will do that, where they fixate the eyelets to the sclera to help with support, and it's for severe zonular weakness. But when you insert it, there's an inserter, and basically the thought is to have this ring, if there's less than 4 clock hours of weakness, support the area and redistribute to the healthy zonules. And so I've never tried this actually, but putting a suture through a primary eyelet and pulling it away as it injects, so it's not stressing the area that's broken, because you want to get past that area so it sits against there. And then, let's see. You want to also visco dissect prior to phaco sometimes, so you can put it in before actually doing any of the phacoing, just to have more support. And you want a stable chamber, so if there is any zonular weakness, you're not forcing vitreous prolapse or aqueous misdirection. And in small areas of rents, you can use a 3-piece to support that area, but You don't want to really put one in the sulcus because if there's a lot of zonular weakness, because that lens will tilt. And this, so I don't know if this will work either. Oh, this is a video from Guatemala that we just went in. It's through a microscope, OR microscope, so it's a little shaky and not the best, but you can see this lens floating, basically, with barely any zonules holding on. Let's see. You'll see it kind of float halfway down and then kind of move back up and stabilize. So this was sent to retina because it was sitting so far back into the vitreous. Oh, and then this was an intracap that was done actually in Guatemala. So what happens first is we, just like an extracap, do a peritomy and a scleral tunnel. And instead of making a rhexis and opening up the capsule, the whole lens with the capsule is taken out. So it's really amazing how quick and efficient they are at these surgeries since they're so used to it. But the surgeon's putting visco behind the lens and just takes it out so quickly. So I think it's on repeat, so you guys can see it one more time. Let's see. Well, let's see. It was like faster than we could realize how quickly it happened. All right, so. And then you can kind of see the vitreous in the back. So vitrectomy was done, and then iris lens was put in. All right. So next is steroid-induced glaucoma. This also mimics primary open-angle glaucoma in presentation and clinical course, but history is really important in these patients. 1/3 of all patients have some response to corticosteroids, but only a small percentage, about 5%, have a very clinically significant elevation. And it will vary based on type of drop, potency, how often, what route, and the susceptibility of patients. So there's a higher incidence in patients with primary open-angle glaucoma or a family history. And I tend to tell these patients that if they respond to steroids, are more likely to develop glaucoma long-term. Can be worse with topicals than systemic, but any of them will cause it, and it can occur at any time during use. And it's due to the increased resistance to aqueous outflow in the trabecular meshwork. So oftentimes patients that start topicals, I tend to see them within 4 to 6 weeks to see if there is going to be a response, not just to topicals, but also any joint injections, nasal steroids, anything like that, if they're at high risk for glaucoma in general. So there's 3 groups. So there's low or no change in IOP, intermediate change where their pressure goes to like 22 to 30, and then the high marked rise, and that's about like 5% of patients on steroids. And then obviously the potency. So Durezol is the worst offender, as well as dexamethasone, and then FML and Lotemax are less likely, but it's still possible in a very susceptible patient. And this is just kind of saying that low, intermediate, and high risk. And so risk factors are open-angle glaucoma, glaucoma suspects, family history, insulin-dependent diabetes, high myopes, very young and older patients, and then patients with connective tissue disease. And then these are all the offenders that we're aware of. So resistance to aqueous outflow, like I mentioned, and that's due to physical and mechanical changes in the microstructure. It can cause cross-linked actin networks into the TM, and so that causes resistance. And then it also inhibits degradation of the extracellular matrix. So like I said, topicals generally within a couple of weeks, but you can rarely see sooner or longer than that. And then they say systemic can be months to years, but I think the more you're exposed to something, the quicker it's going to happen. And so this is a guideline for monitoring, but again, I tend to do 4 to 6 weeks, and then if there's no response, maybe see them again in 3 months, and then 6 months if there's still no response, if they're going to be on prolonged courses. If it's a short course, after 6 months, if there's no response, then I do my normal follow-up, but if they begin treatment again, then it would restart the whole process. So treatment is removing the offending agent if possible, not always possible. So medical treatment's great. SLT is really great in steroid-induced glaucoma. And especially with the retina doctors injecting a lot of steroids. We see this a lot, and so sometimes drops and SLT is not enough and they do need surgery, but I try to avoid that if possible. It just depends how long the course of medication is going to be. We have had to excise like subtenons, dex that was placed in Kenalog because of a prolonged steroid response, because it's easily accessible to remove it, and so you can just cut down the conj and remove as much of that as possible to remove the offender. Okay. Traumatic glaucoma. So lots of different things with trauma. You can see hyphemas, angle recessions, aerodialysis, cyclodialysis clefts, lens subluxation, iris sphincter tears. So this is kind of just a drawing of all the different areas that you can have damage. And so it can be blunt or penetrating. It can happen right away with trauma or years down the road. And it's a combination of the post-traumatic inflammation, clogging with RBCs or white blood cells, and then direct injury that leads to IOP spikes. Chemical injuries, especially alkaline, are really dangerous, and that can occur right away or months to years later, so you want to watch those as well. Hyphemas are important to watch, especially if they're large, because they can cause a secondary pupillary block. You can have rebleeding that occurs 3 to 7 days after initial hyphema. So I usually, if a patient has a hyphema, I have them come back like day 4 or 5 just to see if there's this spike in pressure from the clot breaking down. And then you want to avoid carbonic anhydrase inhibitors in sickle cell patients. So not every patient knows their status, but if they're African American descent, you want to maybe check this lab work just to make sure, because when they sickle, they get stuck in the TM because of the change in shape, and that will cause high spikes in pressure, and they sometimes need to go to the OR to have a washout sooner than others. And then you can have vitreous hemorrhages, and then what happens is these cells kind of break down and become khaki colored, and they're less pliable. And if there's a disruption between the hyaloid face, it can get into the anterior chamber and then clog the TM. And so it usually resolves when the hemorrhage clears, but sometimes we need to have retina go in and clear the hemorrhage if they're having a very large IOP spike. And then angle recession is the tear between the longitudinal and circular muscle fibers in the ciliary body. And so sometimes you can't tell. Some people just have a very deep chamber, but a lot of times what I'll do is look at the other eye and compare just to see if they look similar or very different. And so it's usually unilateral and chronic, can happen years later. History is really important. And then you may see a broad angle recess. It's a little hard, but this picture kind of shows it's really deep. The TM, pigmented TM, the scleral spur, ciliary body, and then it's just like the iris root is so far down. And then this, it's fairly normal, and then it kind of deepens, and you get this white glistening scleral spur that's wider than the rest. So you can treat with topicals. Surgery and SLT is not likely to help because the angle is damaged already. Okay. So uveitic glaucoma. The mechanism for this is multiple factors. So the aqueous is much more viscous in these patients. There's white blood cells and debris that are going to clog the TM. There's dysfunction of the TM because it's just not working well. There's prostaglandins that are releasing, and then scarring of the outflow, and increased epivenous scleral pressure. So there's multiple factors that can affect uveitic glaucoma, and they can present with the typical uveitis symptoms. So different signs and symptoms you might see are KPs, band keratopathy, and chronic cases, dendrites. PAS is common on gonioscopy or posterior sneaky eye between the iris and the lens. The pressure can be low initially just because the ciliary body is not secreting as much as normal, but it can build over time. And then the fundus, you want to make sure that there's no posterior pathology also. And so you want to work. Primary uveitis, I don't necessarily work up, first episode rather, unless there's something concerning on exam. But you want to do a systemic workup. And then treatment is controlling the elevated eye pressures with drops or surgeries. You want to avoid prostaglandins in these patients and miotics because it breaks down the blood aqueous barrier and it's going to make inflammation worse. You'll need corticosteroids, cycloplegics, and then depending on if there's a systemic source, rheumatology can help with different mediators for that. Let's see. And then, yeah, long term, you want to you want to aim to treat the underlying cause to prevent future attacks. And so surgery is usually used for refractory cases. You want to do it when the eye is as quiet as possible. If I do a tube on these patients, I end up doing it 250 because they're more prone to hypotony because they have big swings in pressure when they're in an acute phase versus quiet phase. Trabs can fail just due to having too much inflammation and scarring of the bleb over time. And then goniotomies or GATs are good in younger patients just because their TM is working well. And CPC and SLT are not good options in these patients just because they're pro-inflammatory. So some just subsets of uveitis are Fuchs heterochromic iridocyclitis. These patients have it's rare, it's unilateral, it can be associated with rubella. They have stellate KPs, they can have PSC cataracts, and the affected eye is the hypochromatic eye. And so if you see this with high pressures, glaucoma, you don't want to treat with corticosteroids because it's not actually going to help. You just want to treat the pressure. And then Posner-Schlossman syndrome is usually young patients that have very high pressures, up to like 40 to 60, present as uveitis. And these respond very well to corticosteroids, but you do also need to treat the pressure as well. And they can develop a secondary glaucoma long term. And then juvenile rheumatoid arthritis, about 47 patients will have uveitis, or kids will end up with uveitis of some sort, so something to watch out for. All right, so these are just some photos from Guatemala. So we got tons of donations from lots of companies, which was really nice. This is Dr. Rothstein and myself and some of the team that we went with, but this is mainly the team that's down there, and this is the hospital that they work at. It's a really great, well-run organization. They have 4 eye beds that are set up at a time to operate. This is the waiting room of patients that just waits hours and hours without complaining. It's amazing. And then we actually did a lot of teaching this time for glaucoma just because they don't have a lot of access to glaucoma care down there. So this was me teaching one of the docs there how to do a Bearvelt tube. And then we did a lot of extra cap surgeries, and this was just one of the lenses that we removed. And then just part of their clinic. That's it. Thanks.
Do you want to take any questions? Dr. Shah, do you want to take questions?
Any questions?
I'll come to you if you have questions. No?
I was just saying we have one presentation left, so why don't we go ahead and just push through and we'll get everybody out in time for lunch. So our next presenter is Dr. Siegel. So she took her boards yesterday, so she is at the absolute height of her clinical knowledge of anybody in this room. So any questions she'll be able to answer.
All right, thank you all for being here. Again, I'm Diane Siegel. It's great to meet all of you, and I look forward to working with you all in the future. I have no financial disclosures, and obviously this is the last lecture of the morning, so I realize being the last lecture before your lunch break is a bit like me trying to get in between this lion and her undoubtedly tasty meal. May not be the best idea, but I will do my best to try and make this a clinically relevant and hopefully helpful review of a very common condition. So, is it?
I forgot to put the QR code for that last lecture, so we'll after Diane's done, I'll put that last QR code up for all you guys. Sorry about that.
QR codes to come. So what I'll be talking about today is primary infectious keratitis, and kind of mostly focusing on a clinical approach, how you kind of work these patients up and how you kind of think about it. And we'll kind of cover bacterial keratitis, atypical mycobacteria, fungal acanthamoeba, and then a quick review of some viral keratitis as well. And I thought we'd start off with a case. This is a patient that we'd seen in my residency. So we have a 31-year-old female. She came into the ED complaining of left eye pain, redness, and decreased vision for 5 days. She said it may have started after some exposure to some chemical fumes while making meth. And she doesn't remember the last 4 days. She just woke up with very severe left eye pain. She was initially seen at an outside ER. ER docs took one look at her and sent her over to the university. And she denied contact lens use when seen initially. Her past ocular history was negative. She did have a history of substance abuse and bipolar disorder, history of homelessness, multiple incarceration, so lots of risk factors here. No family history or pertinent medications. So when we saw her, this is what she looked like. Obviously not a great looking left eye there, but I know sometimes if you see a patient like this, you have a tendency, or at least I do sometimes, to kind of, freak out a little bit on the inside, but kind of just taking a step back and making sure that you kind of go back to the basics and just kind of taking a look at the location of the infiltrate or the epithelial defect. You want to document the size and the depth of the corneal infiltrate, because that's going to be helpful as you follow the patient going forward. And then you want to look carefully for any signs of an anterior chamber reaction, so any signs of cell, flare, fibrin, or hypopion. All of that should be kind of documented, especially if you're going to be transitioning this care off to another provider. And then I also think it's always helpful to take note of presence of any foreign bodies, blepharitis, entropion, trichiasis, lag ophthalmos, anything that may have kind of predisposed the patient to infection. That kind of goes into that there. So this was her initial exam. Kind of the pertinent positives here is that the left eye vision was hand motion, which you'd expect to see with a cornea that looked like that. Very diffuse conjunctival injection, and the left eye was noted to have essentially limbus to limbus epithelial defect with an underlying stromal infiltrate, and then some of that infiltrate sparing nasally. No perforation or thinning was noted. And then a pretty difficult view further back than that, but there was some thought that she may have had a hypopion there as well. So from here, next step, curious to hear what you guys might think, or maybe you can think to yourself, but what we did next was we did a B scan. So what you're looking for on a B scan when you don't have a view posteriorly, obviously, is you want to make sure that, especially in a patient who's coming in with all these risk factors, you want to make sure that you're not seeing signs of endophthalmitis. And so obviously it's not a perfect tool, but that can be helpful in kind of, thinking about what your next management steps will be. All right, and so thinking obviously about a diagnosis for, a differential diagnosis for corneal ulcer. And then I'll take a pause here, and I'm sure we all know this, but I think initially when I started, it was confusing. What do people always talk about corneal ulcer? What does that mean? An ulcer just implies tissue loss, of course. It may or may not have an infection. So when you think about the diagnosis here, kind of dividing it up into infectious causes versus non-infectious causes. And then infectious is obviously where we'll be focusing today, thinking about bacterial, fungal, acanthamoeba, viral etiologies. And then, of course, there's also some non-infectious causes as well. So, I'm sure we've seen patients who've either taken or had topical anesthetics prescribed to them. That can, of course, lead to ulceration. Autoimmune causes like peripheral ulcerative keratitis, a shield ulcer from some sort of atopic disease, and then neurotrophic or exposure keratopathy as well. All right, so we've kind of thought about our differential next steps from here. We culture. So Obviously, in that case, it's very clear that we need a culture here. But let's just take a step back and think about when to culture. These are from the American Academy of Ophthalmology, but essentially, you want to culture when the infiltrate is central, large, generally greater than 2 millimeters in size, associated with significant stromal involvement or melting. If you're treating an infection and it's chronic or it's not responsive to the initial broad spectrum antibiotics you've been treating, that's when you'd want to think about culturing as well. In those cases, you may want to hold antibiotics for about 12 to 24 hours to improve the yield of your culture. Any patients who have a history of corneal surgeries, atypical clinical features on exam, we'll kind of discuss a little bit more about this, but essentially if fungal, amoebic, mycobacterial causes are on your differential, you'll want to culture those as well. And then of course, infiltrates in multiple locations on the cornea. The one caution here with culturing is if there's significant thinning or a desmetocele, you do want to maybe take a second to be extra careful in those cases because you obviously don't want to cause a perforation there. Kind of going back to some of the basics here, tips for corneal culture. Anesthetize the surface of the eye with some proparacaine. I was taught to avoid tetracaine. It's thought that might have a bactericidal effect and that can impact the yield of your cultures. I sometimes would put, because these patients are often very photophobic and don't like their eyes being manipulated, sometimes I'll just grab a lid speculum and just pop that in just to make it easier to get the sample that you need. And then as far as what you use, many different options out there, spatulas, a sterile needle, a surgical blade. I often tried to grab a calcium alginate swab, so this one here on the right. And then you swab it directly onto your culture plates. Was always taught to kind of make that in a nice C for cornea shape. You can see that kind of highlighted here. I think that helps the lab kind of identify, help distinguish from contaminants versus kind of what was intentionally plated. You of course want to avoid the lids and lashes to help improve the yield and accuracy of your results. And then the other thing that can be helpful, especially in these severe cases, is once you've cultured and plated, you can, if you have some 5% betadine lying around, just go ahead and put a couple drops on that. You can kickstart the process of getting these infections treated. And then another thing to mention is if these patients are contact lens wearer and they have their lenses or their cases available, it's pretty easy to get a quick culture of those, and that can be helpful as well. So wanted to quickly review some of the plate options that you can grab to culture these infections. So we have blood, chocolate, thioglycolate broth, and these are kind of for your aerobic and anaerobic bacteria. Chocolate agar plates for Haemophilus, Neisseria species and other aerobes. Sabouraud's is for fungal species. And then you want to grab the non-nutrient agar with E. coli overlay for acanthamoeba, and then there's a bug up here. And then a viral media, if you're concerned about herpes simplex or other viral etiologies. Sometimes if you kind of forget this, it's always helpful to give the lab that you're working with a call and just kind of say, this is what I'm looking for, and they can always guide you on what to grab and what plates to inoculate. And then you can also consider getting gram stains on slides. It's not always the most practical thing to do, so I don't know that I always did that, but these were definitely the basics here. So going back to our case, she was obviously cultured. We ended up making the decision to admit this patient because of how severe the infection was and some of her social risk factors, very concerned about follow-up and her ability to kind of apply the medications as we needed. Obviously, you kind of take that on a patient-by-patient basis, but that was the decision that we made there. And she was started on fortified vancomycin every 1 hour. We started her on oral supplementation with vitamin C and doxycycline, and then COSAP because she did have a little bit of an elevated IOP. So we'll talk a little bit more about some of these options later. So her culture results came back. It ended up growing out a variety of different species. She showed some initial improvement, so we decreased the fortifieds, and then she was eventually discharged a couple weeks later on a regimen of, we transitioned her over to just Vigamox every couple hours, prednisolone, and atropine, and I'll kind of talk a little bit about kind of that management of bacterial keratitis there shortly. And then as you might expect, this patient did not follow up very well. I think she ended up coming back to the clinic like 3 or 4 months later, epithelialized with a lot of neovascularization, and was continued on some steroids and antibiotics, but ultimately did not have great adherence to therapy or to her clinic visits after that. Unfortunately, that ends up being the case with a lot of these folks. But I'll kind of transition to talking about some of the main etiologies of infectious keratitis, and then we'll first talk about bacterial keratitis. We've got a Staph aureus infection here. Talking first about risk factors, I'm sure we all see this, every day, if not every week. Contact lens wear being associated with the vast majority of cases. I think looking at some of the numbers, the risk of infectious keratitis is increased tenfold in contact lens wearers. That risk, of course, is higher in patients who wear their lenses overnight, and then it's also positively correlated with the number of days that lenses are worn without removing them at night. So definitely a risk factor that you always have to screen for. Patients can have trauma as a risk factor. Anyone who has a compromised ocular surface, so the eyes are dry, maybe eyelid misdirection with some trichiasis or entropion, frequent topicals, any patient with a history of PK, like you can see here, this patient obviously has a history of PK, and immunosuppression can of course raise that risk of infection as well. Incidence, there's about 71,000 cases of microbial keratitis that occur annually in the US. The most, and that includes bacterial, fungal, acanthamoeba. The prevalence of a particular organism definitely depends on the geography and the patient-specific risk factors for the infection. So, but of course, the most common bugs are going to be your staph and strep species, and then Pseudomonas is definitely something that we consider in our contact lens wearers as well. Neisseria and some of the other species that are listed here are much less common. And then up to 43% of cases can actually be polymicrobial as well. So important to initiate broad spectrum coverage. Clinical presentation, of course, rapid onset of pain and light sensitivity. They will obviously have decreased vision and conjunctival injection. The rate of symptom progression is often related to the virulence of the infecting organism. I have a picture of Pseudomonas there on the right. Typically, it starts off as a single infiltrate. There's usually like a pretty sharp epithelial demarcation, and then there's kind of underlying, very dense, suppurative, kind of pussy-looking stromal inflammation, and that usually has some indistinct edges, and there's often corneal edema that's associated with that. Pseudomonas often has a much more like kind of necrotic appearance. There's often an adherent kind of mucopurulent exudate. The cornea often looks quite soupy. And then alongside this, you can see quite a prominent anterior chamber reaction. So like an endothelial, like inflammatory plaque, a hypopyon, which you can see in this picture here as well. So all of that can be seen. Initial therapy, you always want to start with something that has broad coverage, so broad spectrum antibiotics. So for some of your kind of lower risk infections, these are ones that I would define as being smaller, certainly less than 2 millimeters, peripheral, not significant stromal involvement. You can start, second generation fluoroquinolones are sometimes reached for, like Oflox and ciprofloxacin. Those do have really good Pseudomonas coverage, but they do lack some of the gram-positive activity. So I have typically reached for the third or the fourth generation fluoroquinolones, such as moxifloxacin. They have great penetration into the anterior chamber, improved coverage of gram-positive bugs, like your staph and strep, and along with atypical mycobacteria. It does have limited MRSA coverage, so if you are worried about MRSA as a bug here, that's when you'd want to think about adding vancomycin as well. And then infections that are vision threatening, larger infections, certainly like the case I first presented, that's when you're going to want to reach for your fortified topical antibiotics. You can use an agent that has good coverage of gram-positive bacteria, so I've usually used vancomycin in the past, and then another agent that has better gram-negative coverage, so tobramycin. It's usually what regimen I've used in the past. The downside of the fortified antibiotics are that they are quite expensive and they can be kind of difficult to obtain. You typically need access to a compounding pharmacy to get access to those medications, and they do have increased toxicity, so they can be associated with increased epithelial toxicity. Additional management considerations. So obviously starting antibiotics, what else are we going to do? So of course we're going to culture before we give any other antibiotics. Severe cases, you can give a loading dose of antibiotics in the clinic. So that's kind of the betadine rinse I mentioned initially, if that's all you have available. Or if you just happen to have a sample of Vigamox or whatever in the office, you can start giving that every 5 to 10 minutes while they're in the office for the first hour. You can get great penetration into the anterior chamber through the stroma by doing that, and it gives them a head start on kind of clearing that infection. So given that it can take a little bit of time for them even to pick up antibiotics from the pharmacy or certainly even compounded topicals, I think that's a great option to do. Another important thing to remember is that these patients are, of course, very uncomfortable. If there's anterior chamber reaction, hypopion, you can consider doing cycloplegics for comfort, and that can sometimes help prevent synechia as well. So obviously either cycloplenolate or atropine, depending on what's available. You can consider a shield if there's any concern for corneal thinning. Of course, having the patients out of their contact lenses while all this is going on. If you can consider adding an oral fluoroquinolone, especially if there's concern for scleral extension or impending perforation. These orals do have excellent ocular penetration, so great option for that. And then another thing that I will typically recommend adding is vitamin C or doxycycline oral supplementation. The thought is that the doxycycline helps decrease inflammation. It contains matrix metalloproteinase inhibitors, which can help stabilize the collagen and help promote epithelial healing. Topical steroids is always a big question, and I'll talk a little bit more about that, but there can be a role for topical steroids in certain cases. Amniotic membrane transplantation can sometimes be used in recalcitrant cases if there's delayed epithelial healing. And then, of course, if there's perforation, you essentially want to treat that like an open globe. So if it's small, maybe less than 1 or 2 millimeters, you can consider doing corneal glue with a bandage contact lens versus kind of more aggressive surgical intervention with like a patch graft or a PKP. As you are following these patients, you obviously want to see these patients, a severe infection, certainly daily initially, and then as they improve, you can maybe start to space those visits out. But what you're really looking for is the clinical response. So sometimes the first thing that comes in, the eye still looks terrible, but they're saying, I feel better, the eye's less red, there's less discharge, the lids are less swollen, there's less injection. And then, under the slit lamp, you're looking for signs that the, infiltrate perimeter is getting a little bit smaller. The infiltrate is less dense. There's less edema. The AC inflammation is improving. The cornea is reepithelializing. And then if there was concern for corneal thinning previously, seeing that essentially sort of stop there. And then as you're seeing clinical improvement, as you get your culture results back, you can narrow therapy. And then I'll say a word, sometimes you get those sensitivities that come back from the lab, like the readout of the report. You don't necessarily have to follow those exactly because the antibiotic, the sensitivity reports are essentially based off of tissue levels that are achievable by systemic administration and not necessarily by the topical administration of the drops that we're doing. So usually topical administration can achieve much higher levels of concentration in the tissue of concern. So you don't necessarily have to go by that. If the patient is responding to the therapy that you're on, even if the sensitivity report suggests no, you don't necessarily have to follow those guidelines. So essentially, clinical response is how you guide therapy. So I wanted to talk a little bit about the steroid use in corneal ulcer trial, or the SCUT trial. There's been a lot of different kind of controversy about when to use steroids, when is it a good idea to use steroids. This is one of the randomized controlled trials that kind of specifically studied that question. So I think over 1,700 patients were screened for the trial, 500 patients ended up being enrolled. They cultured all of the patients with ulcers, and they were all treated with antimicrobials for at least 24 hours. If they were culture positive and the thinning was stable, they were randomized into two groups with the addition of Pred Forte versus kind of simply continuing on the Vigamox. But if patients had any thinning or significant thinning, steroid initiation was delayed. And essentially, the outcomes were kind of interesting. At 3 months, there was essentially no difference in best corrected visual acuity, the time to reepithelialization, the scar size, corneal perforation rate, and the complication rate. They did do some subgroup analysis, which revealed that steroids could cause a larger scar in nocardia positive infections, although there was no difference in best corrected visual acuity at 12 months. And then I'll kind of pause here, is that one of the weaknesses of this trial is that I think up to 90% of patients in the trial were actually from India, not contact lens wearers, and were agricultural workers. So some of the microbiology may be a little bit different than kind of what we see more commonly here. However, in non-nocardia ulcers, early steroids may contribute to better visual outcome. However, it was shown to have improved by 1 line compared to the controls at 12 months. So an improvement, but maybe not a huge one. And the paper kind of summarizes and says that they felt like larger ulcers did receive a greater benefit from steroids. But again, severe thinning was excluded from the trial, so it's kind of hard to draw conclusions. So, and then in patients with underlying fungal or acanthamoeba infections were completely excluded from the trial as well. So, can be difficult to draw conclusions. So, what do we do with that information? So, if you're thinking about starting steroids, I would not use that without appropriate antibiotic therapy. You have to be confident that there is no other associated very virulent or difficult to eradicate organisms are kind of playing a role here. So, acanthamoeba, nocardia, fungal, viral causes, you want to be very cautious with that. And then you want to choose the correct patient selection here. So patients must be able to come back for frequent follow-up visits, and they must have demonstrated really good adherence to the therapy thus far. So kind of the guidance is that you can kind of cautiously initiate steroids, prednisolone acetate 1%, 4 times a day, preferably after at least 48 hours with an identified organisms or showing clinical response to your initial therapy. And then you'll want to recheck that patient again at 1 day and 2 days. And then if the patient's doing well, no adverse effects, you can consider adjusting the frequency based off of the clinical response. So I wanted to try and quickly show, let's see if this will. But essentially this is a patient who had a perforated corneal ulcer. And I mentioned that you can consider doing corneal glue. So this is just a little video of that happening. But essentially what we are doing here is you cut a small circle slightly larger than the size of the defect using sterile drape material. You can apply a little bit of ointment to one side and use kind of a sterile cotton swab, which is what she was doing there, and then some cyanoacrylate glue to the other side. And then you essentially just apply that to the area of perforation, and you can use a large gauge needle to kind of smooth out your little graft there and kind of make it adhere to the cornea, and then apply a bandage contact lens over the defect. So, this patient may likely need additional surgical intervention, but this can be a helpful temporizing measure. Here, so she's just adjusting that there. So then we'll transition and talk about atypical mycobacteria. This is a picture of a Mycobacterium fortuitum infection. It's thought that atypical mycobacteria are responsible for up to 50% of post-LASIK infections. It's thought to be related to the anoxic environment of the flap. Clinical presentation, you want to consider this in delayed onset post-LASIK infections. Most of your early onset LASIK infections are still going to be your most common staph and strep type species. And these are going to be kind of present with sort of a recalcitrant, non-suppurative infiltrate. The most common pathogens, Mycobacterium fortuitum and Chilone. I actually don't know how to say that out loud. And these bugs are often found in soil and water. You can make the diagnosis using an acid-fast stain or culture with Lowenstein-Jensen media. Like Justin mentioned, I just took my boards. All of this stuff is fresh in my mind. And then for treatment, as I mentioned earlier, the fourth generation fluoroquinolones do have good coverage against the atypical mycobacteria, so that's a good option. And then you can also use clarithromycin as well. Transitioning over to fungal keratitis. These are found to represent about 5 to 10% of corneal infections. Again, geography plays a big role here. So it is more common in warm or humid areas, so maybe not here in Colorado, but you'll see a lot of fusarium in the southern US, Canada and aspergillus more frequently in the north. Biggest risk factors with these are going to be a history of trauma with plant or vegetable matter. That's when you want to start thinking about that possibility. Again, our contact lens wear, and then anything that might make the patient immunosuppressed. So topical or systemic steroid use, maybe a history of diabetes, something else that might make the patient immunosuppressed. And then any history of chronic corneal surgery or chronic keratitis. Most common implicated pathogens are again going to be the Fusarium, Aspergillus, and Candida species. And then just kind of interesting to note, I think back in 2006 there was an outbreak of Fusarium keratitis that was associated with a multi-purpose contact lens solution on the market. So that was eventually, of course, recalled, but definitely important to keep that in mind as well. And this is a picture of Fusarium keratitis here. So clinical presentation. So you want to think about this when if you're treating a presumed bacterial infection and it's failing to heal as well as you'd hoped. Initially, there's fewer inflammatory signs. You'll see a lesion that's kind of has irregular filamentous kind of margins, a little kind of filament-like margins there. You can develop a deep stromal infiltrate that can occur even in the presence of an intact epithelium. And then later on, they can develop a very intense inflammatory picture. So again, an endothelial plaque, hypopyon, angle closure, even from kind of an inflammatory pupillary block. And it's another kind of pearl is when compared to bacterial keratitis, the pain may be kind of appear out of proportion to the relatively uninflamed appearance of the cornea. Sometimes they can develop these early on superficial lesions that are kind of gray-white, a little bit elevated, with a dry kind of gritty texture. And then when you're wanting to evaluate for this, you want to grab the blood or the Sabouraud's agar. And this can be quite difficult to diagnose. You may need to do repeat kind of corneal scrapings to kind of establish the diagnosis. For treatment, so topical agents, if you're concerned about or have evidence of Fusarium or Aspergillus, that's when you reach for natamycin. Candida infections, you'll reach for amphotericin B or voriconazole. For severe infections, adding on a systemic agent it might be a good idea, especially if there's deep corneal invasion or intraocular spread. Voriconazole is an agent that I've seen used quite frequently. It has excellent intraocular penetration. Ketoconazole and fluconazole have also been used. Intrastromal injections of these agents have been tried for deeper, kind of more recalcitrant infections. And then sometimes you may even need to go in and debride the epithelium to allow for better penetration of the topical therapy. And then we'll transition to talk about acanthamoeba keratitis here. We've got a classic infiltrate, ring infiltrate here. So acanthamoeba, a little background. It's a ubiquitous protozoa. It's found in both freshwater and soil. It exists in two forms, like motile trophozoites and dormant cysts. And this kind of, the dual forms are kind of what makes it so difficult to treat. It's very resistant to killing by freezing, desiccation. The standard levels of chlorine that you find in pools, swimming pools, and hot tubs do not get rid of these, so that's always a risk factor. They can attach to the corneal epithelial cells via a mannose binding protein and can subsequently invade the stroma using various collagenases. Again, risk factors, contact lens use comes up again, especially in folks who are, swimming in their contact lenses, showering in their contact lenses, exposure to potentially contaminated water. Up to 85% of all cases of acanthamoeba occur in patients who do wear contact lenses. I found, up to 33 cases per million contact lens users is the incidence, and it does seem like the number of cases have been on the rise over the last 20 or so years. So clinical presentation. So initially pain out of proportion to the clinical findings, decreased vision, redness, foreign body sensation, light sensitivity. And then in the early stages of the disease, this can be quite difficult to catch. Up to 75 to 90% of patients are misdiagnosed, and that's unfortunate because an early diagnosis is going to lead to a much better visual prognosis. Early disease, it's hard to kind of make this diagnosis. It's less than 1 month. It can just look like an epitheliopathy, kind of punctate keratopathy. They may have some pseudodendrites. And then the ring infiltrates that we hear about and we read about are actually more common in later disease. And so the most common misdiagnosis of early acanthamoeba is HSV keratitis, just because of that dendritic appearance there. So kind of wanted to talk a little bit about when you should be kind of thinking of acanthamoeba versus HSV. Essentially when you're seeing kind of a non-contiguous or sort of a multifocal pattern of the granular epitheliopathy and then some sub-epi kind of opacities, unlike the more contiguous dendritic pattern in HSV. They'll have disproportionately severe ocular pain. And then again, they'll have those risk factors like contact lens use or exposure to fresh water. And then, you may treat these patients initially. I think this is often how the diagnosis is made. They're started on the appropriate HSV keratitis treatment and they're not responding to that. That may be when you want to think about acanthamoeba. And this is an example on the left here of HSV dendrites. I don't know if it's coming out well enough on the slide here, but they often have, the HSV keratitis the dendrites have these terminal bulbs here, whereas the acanthamoeba pseudodendrites don't have that terminal bulb-like appearance. It's a much more kind of granular appearance. So you really want to take a careful look at that, but it is a tough diagnosis to make. And then this is an example, or some pictures of the radial perineuritis that you can see in acanthamoeba. This is apparently pathognomonic for acanthamoeba. And then it kind of plays into the reason why acanthamoeba is so painful. So the bug has a propensity for perineural invasion, and that causes quite a bit of pain. These, you can see kind of these whitish lines that are oriented more or less radially in the cornea. So if you see that, that is pathognomonic for acanthamoeba. So, and then this, just a quick slide on some of the later disease presentations of acanthamoeba. So again, that ring infiltrate, and then of course a very advanced presentation of frank ulceration, and with a significant anterior chamber reaction as well. So this can also develop into a scleritis, corneal melt, perforation, and even cause some posterior segment inflammation as well. So diagnostic evaluation, this can be tough as well. Only 35 to 55% end up actually coming back with positive cultures. We may need to pursue doing a lamellar corneal biopsy to actually definitively establish the diagnosis. This often comes up on boards, but the smears that you can look for, these bugs, GAMSA, PAS stain. Again, as I mentioned earlier, for culture, you'll want to grab the non-nutrient agar with E. coli overlay, and then you'll see if it grows out, these kind of trails that form across the plates. You can use confocal microscopy as a non-invasive way of making the diagnosis, so you can actually use that to visualize the organisms, particularly the cyst forms, which I will show here. So this on the left is confocal microscopy, so you can see these kind of high contrast round objects which represent the cysts, and then some of these more irregular forms that are suggestive of the trophozoites, and these are kind of those characteristic trails that the acanthamoeba form across the non-nutrient agar plate. So talking a little bit about treatment and management, the class of therapy that we typically reach for are the biguanides. They have, and the reason for that is that they have efficacy against both the cyst and the trophozoite form. Two biguanides that are commonly used are the polyhexamethylene biguanide or chlorhexidine. But the treatment time is quite long. So even if the diagnosis is made early and the disease is kind of just limited to the epithelium or the anterior stroma, they can have excellent visual prognosis, but you're still looking at 3 to 4 months of treatment. More severe infections with deeper stromal infiltration, a ring infiltrate, especially extracorneal involvement, you're looking at treatment of up to 1 year in length. I haven't seen this used as much, but you can consider using topical immunosuppressants. There's some thought that the body's robust inflammatory response leads to some of the morbidity associated with the infection. So if after 2 weeks of antiamoebic therapy, you can consider doing that to kind of help improve the healing process. And then after therapy completion is when we can consider keratoplasty for visual rehabilitation. And then I just wanted to touch, again, kind of mentioned it a little bit earlier, but on herpes simplex keratitis, because that's so often typically confused with acanthamoeba. I can obviously spend a full hour just talking about viral keratitis, but I just wanted to include this here because the epithelial form of the disease is certainly in the differential for infectious keratitis. But as we all probably know, it's one of the most common causes of corneal blindness in developed nations. You can see herpes simplex, almost anywhere in the eye. The major forms of keratitis that we think about are the epithelial disease, stromal disease, or an endothelial disease. But of course, it can also cause a retinitis, a trabeculitis with IOP spikes, uveitis, and optic neuritis. But the most common presentation that we'll see in clinic is a blepharoconjunctivitis, typically heals without scarring. When you get an epithelial keratitis, again, you see this classic picture here of that dendritic lesion with terminal bulbs. And then the infection can lie dormant in the trigeminal ganglia, but it can reactivate down the road, leading to corneal scarring, necrosis, and then feared complication of a neurotrophic cornea, which can be quite difficult to manage. And then the treatment will, of course, be your oral antivirals are going to be the mainstay for that, with the possible addition of topicals as well. So we'll just kind of wrap it up here. Just a few kind of take-home points. Of course, the majority of community-acquired cases of infectious keratitis, resolve with empiric therapy with Vigamox. But you want to make sure that when you're seeing something that's larger, central infections, something that has the potential to be visual threatening or has some atypical features, definitely will want to culture those. You'll want to reconsider the diagnosis if it's not responding to initial therapy. Keep acanthamoeba fungal infections on your differential. Don't forget to add on a cycloplegic agent for significant AC inflammation that can help quite a bit with patient comfort. And then, of course, we can consider the judicious use of steroids for appropriate cases, but do have caution because there is significant risk of complications when that's not done correctly. All right, thank you. Hopefully that was helpful.
Does anybody have any questions about any of the talks today, or any other general questions or comments? Or yeah. Yeah, so the question was, she was talking about the amniotic membrane contact, that Procera, and we do have it in the freezer in the office. So anybody who needs one of those urgently, we can just pop those right on. They just defrost and just gets popped right on. Yeah. That is a good question. I don't think so, because we've been using the Procare. I personally don't really put it on ever. Dr. Werner uses it mostly. But I feel like I would have heard about it if there was an issue with the insurance. So typically I don't think there's an issue with it. But I'll double check with Dr. Werner and see if that's, I don't know if we have to get a
I've not heard of it. I've not heard of issues with it, so.
So I don't think so. I don't think we have trouble getting it covered, yeah. Okay. All right. Well, thanks for spending your Sunday morning with us. We really appreciate you guys coming out. It was great to have everybody in person again. It's much better, much more fun to see everybody in person rather than sort of looking at a list of names on a Zoom screen. So Priscilla has just some. If you guys are interested in grabbing some water bottles at the back table. Was there anything else we needed to talk about? Also wanted to say an important thing. Say thanks to Priscilla for setting this up because, yeah. I mean, she really spends a countless number of hours getting this all set up and chasing us down to get the talks in and getting them approved and really getting everything all set up. So thanks. I mean, this really turned out fantastic, and it was great to be back in person. So
I love seeing all of you. And, any questions, any issues, you know how to get a hold of me. And I can do pretty much everything from my office. So we're all okay.
yeah, I mean, and the other thing, I know sometimes, obviously we're a big group, and sometimes some things can, communication can fall through the cracks or things like that. And I'd really encourage, if you guys have any issues with notes you need to get or anything, either reach directly out to Priscilla, or probably the best thing is just give one of us whoever the patient saw, or just give one of us a call directly. I mean, if you have questions, all of our cell phone numbers should be in all of the referring materials, and it's much better, just give us a call directly and we can talk the patients over with you and go there. And, we really want to work on this as a partnership, and it really works better when we take care of the patients with you and do everything together, and that's sort of our goal. And I know sometimes, everybody gets busy and sometimes we forget to send a letter or things like that, but just reach out to Priscilla or just call us directly, and happy to go over things. So thanks.
I'll be getting all their cell numbers to you, so you'll be getting that. Some of you have that already. And we have a referral brochure back there too that was specifically designed for your offices, where it's only our specialists that are in there. And thanks again.